So good day everyone, I'm Festus from the Concept Academy. I welcome you to this webinar for Step 2 Cardiovascular System. I am the president of the Concept Academy and I want you to feel quite relaxed while I take you through the journey of cardiovascular systems Step 2. As we always say, we are not in any way projecting ourselves as the expert in the field. We are only trying to help. So if at all you expect us to say it in a particular way, and we are not saying it that way, don't be annoyed. We are not the experts. But whatsoever you are going to gain from us is going to really make a lot of sense. We have like a couple of hours to spend together today. Not to feel bored, get yourself a cup of coffee so that you will still be awake. So we'll be going through the ECG for Step 2, cardiac physical examination, what you want to take into the exam, arrhythmia, cardiac life support basics. We'll just flee anywhere we get to, we stop. So I'm going to be starting with the ECG. Yeah, we are quite aware of ECG. So the bottom line of it is not to make you the ECG expert. So if you are preparing for the exam in such a way that you must be able to read all ECGs, the ones they are giving you in real life and in dreams, I think you are making a very big mistake. Just for you to have an idea of the basic things you must never forget. Anytime you see ECG like this in the exam, you focus on the heart rate, you focus on the rhythm, is it regular or irregular? You focus on the axis, you focus on the intervals. I will show you one or two points in each of them. So the best book for your Step 2 is still your first aid. But there is a way first aid is written. Don't say you hear it from me. I don't know wherever this meeting is going to get to, but it's actually written in such a way that when you see key fact, most likely it has been tested before. That's one thing you must not. So you can actually sit down with the key facts and just revise all the key facts and go for the exam in all the systems. So with respect to the heart rate, they know you know it, but how will you be calculating the heart rate? So you can actually use this 300 divided by the number of large boxes. So what does that mean? When you look at the ECG like this, you see all these boxes you are seeing, these are the large boxes. So you just look at the RR interval and try to count the total number of the large boxes between them. So for instance, if you look at this one, this is looking like 3.5. If you look at my cursor here, up to this point is like 3.5. So if you want to determine the heart rate for this patient now, it's going to be 300 divided by 3.5. So that will now give you an idea of the heart rate. So the normal heart rate should be between 60 to 100. So if you are getting something like 110, so you will be thinking towards tachycardia. You are getting something like 54, 55, you'll be thinking towards something like bradycardia. So if you look at it, it's not something that is difficult. Just for you to look, to think, and to pick your answer. All right, so that's that. What about the large box again, the small box, in terms of the duration? So in terms of the duration, so that's for horizontally. When you look at it horizontally, the large box is actually 200 milliseconds in terms of duration, while the small box, this small box that you see that occupy the large box, so each of them is 40 milliseconds. All right, so you will see where that. So if you can revise this will really make a lot of sense for you. Now let's start with the rate. So when I mention the rate, the question you should be asking is, what are they going to, are they likely to ask me in the exam with respect to the rate? So, and I will try as much as possible to explain everything to you. Are we together? Are we still together?
Yes, sir.
All right. Okay. So now start with the rate. The normal adult heart rate is 60 to 100. So when it's less than 60 in the exam, you'll be thinking towards bradycardia. So for all you care, when you get into the exam, they will just give you the ECG, and you don't forget you start from the rate when you get into the exam. We know you have crammed, or you are cramming a lot of pathology. So sorry to disappoint you. You know, when God wants to really show off in your life, you that you don't know ECG, they give you the normal one. The person that is claiming I have mastered all ECG, they give that person the complex one. So keep it simple, think simply. Most of the time, what you are thinking, you attract into the exam. Think simply. So when it's less than 60, you pick bradycardia. When it's more than 100, you pick tachycardia. All right, so that's the first statement. Now, what are the common causes of sinus bradycardia? This sinus actually gives you an idea of the rhythm. Sinus rhythm is coming from the sinoatrial node. All right, so this is the most tested concept with respect to the rate in the exam. So they will just give you the normal reading. How will you know that it is sinus? You know that the rhythm is sinus when you see P wave preceding the QRS complex. When you see P wave preceding every QRS complex, that's when you know that this is sinus in origin. So when you see P wave preceding the QRS complex, you say this is sinus. So when you now see that, but when you calculate the rate is less than 60, what are you going to be thinking about? Now, you are now expected to look at that question again and check, is this person an athlete? If the patient is an athlete, that will be the answer. Do you get it? So physical fitness. That's, I put an arrow here because it's one of the most tested concepts. Because United States is a place where they actually embrace a lot of what do you call it? Athletic activities. Permit me to use that. So physical fitness is actually one of the things that you can peg on the order of the day. So when you now see a patient that has been trying to, like, maybe run, jog here and there and different, just to maintain the body shape, this person is coming and you calculate the heart rate and it's now less than 60 before you start shouting for help. Help, help, help. No, 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 no. Don't tell the patient you are dying. No, it's just the physical fitness. So that's just what they want you to bring so that you won't raise a false alarm. All right, so physical fitness, check out for it, an athlete and the like with low heart rate. It's not a bad thing. It's just that physical fitness that is causing that. The next one is something like sick sinus syndrome. So when I get there, I'm going to show you. So usually you can see this in what do we call it, the elderly patient. So you are seeing this because United States is a place where you see a lot of elderly people. So you are seeing this 80-year-old woman that is coming to the hospital for one thing or the other. You calculate the heart rate, and the heart rate is maybe 54. Before you start shouting, mama is not okay. No, now. So likely it's just a sick sinus because as we age, there are some degenerative changes that will occur. So that will explain this. So these are the scenarios you should expect. The next one could actually be drugs that could just reduce the heart rate. Who knows? The patient may be on beta blocker. The patient may be on on calcium channel blocker. non-dihydropyridine calcium channel blocker. Then vasovagal attack. You see, anytime there is outburst of the vagal tone or increase in the vagal tone, so you realize that what do you call its name? The heart rate is going to drop. So the heart rate is going to drop. So for instance, the patient is shaving, and the patient just maybe slump while shaving, or the patient just feel a bit dizzy while shaving, and you're like, they check the heart rate around that time, and the next thing is the heart rate is very, very low. So anyhow, the question comes, so you'll be thinking towards vasovagal attack. This patient is wearing a very tight collar shirt, and the next thing is, by one reason or the other, the patient just feel a bit dizzy and just slump. That might be coming from vasovagal attack. So what you have there is like excessive discharge of the parasympathetic nervous system. Do you get me? Or supply to the heart. So that's this vasovagal. Never forget it, vasovagal. MI is also a very good example. So, but these ones, they hardly test them in the exam. Then increase in intracranial pressure. I think we are all aware of this. So, but with respect to this sinus bradycardia, never forget the physical fitness for the United States. Then what are the common causes of sinus tachycardia? All right. So these are the causes: anxiety, anemia. These are the things you know. So when you see them in the exam, you won't really be amazed. Thyrotoxicosis, hypovolemia, and the likes. All right. So that's for the rate. Can you see the way you look at it? Very simple and straightforward. Now, with respect to the reading, so we have what we call the sinus reading. Sinus just means that the sinus reading is actually the normal reading of the heart. So it originates from the sinus node. So never forget that. So never forget this. SA node. Never forget that. All right. So what do you see? You see a P wave that precedes every QRS complex. So think about it. You get into the exam, you check, and you are not seeing P wave. You are not seeing any P wave. So most likely, the P wave is actually coming from the atrial depolarization. So most likely the atria, they are not really contracting the way. So you can be thinking towards something like atrial fibrillation and the likes. Do you get it? So, but never forget that for the sinus reading, you see P wave preceding the QRS complex. Very simple and straightforward. You can see the way you are looking at it. So really nothing much. Then you come down to the axis. So though USMLE does not usually test the axis of the heart in the exam, but what of if you get into the exam and you start seeing them testing the axis before you start shouting our name here and there and be like, go and bring me the head of Festus, bring me his head? No. Let us still show you, because just for information's sake. All right. So with respect to axis, we have what we call leads that normally with respect to ECG you arrange on the patient. We have the limb lead, we have the precordia and the likes. All right. So, but out of all the leads that you already know, the ones you will be using that I will suggest to you, some literature may suggest another ones, but the one I will really suggest to you to be using is this lead 1 and AVF. So let me just try to illustrate what is going on with respect to lead 1 and AVF to you. All right, so let us assume that this is the heart. So let's assume that this is the heart. So we have some leads. So let me put it inside a cycle for you, just for simplicity's sake. So I do not need to be perfect, but just for you to get the illustration. All right. So if you divide it, you can see the heart inside. You can just divide it like this. Permit me. Just also have an idea of the lead. So this is actually your lead 1. Can you see? This is your lead A, V, F. So these are the 2 leads I'm going to be using. So if you look at it, we can actually just assume that with respect to the orientation of the heart, these 2 leads, 2 of them are actually positive. They give all the normal orientation of the heart. So you can see the way the heart is pointing like this. So when you look for the resultant of these 2 arrows, the one, you can see my cursor here and this one, this is actually what you get. You get something like this. This is what you get, and this is actually how the apex of the heart is pointing. Can you see? All right, so it means that when I look at the question and you check for lead 1 is positive, the next lead I want to quickly check is lead AVF. Is it positive? What am I actually checking for there? Do you get me? You're actually checking for the arrow wave in them, or you just say the QRS complex. The QRS complex, is it positive? Is it not positive? So if the QRS complex is positive in lead 1, that is, and in AVF is also positive, you say that is normal orientation of the heart, normal axis. So the next thing I want to do is, let's assume that lead 1 is positive. The lead AVF is negative. I will take my negative as going up here. Can you see? So I take my negative like this. So this is positive. So if you look at it, so the heart is going to be here. So you call this left axis deviation. Can you see? This is positive, this is negative. Take this as negative. The next one is, what if the AVF is positive like this, but lead 1 is going in opposite direction, in this direction like this? So this is going to be the resultant axis. Can you see? So you call this RAD, right axis deviation. What if lead 1 QRS complex is negative there? In AVF2 is also negative. So this will be the extreme. So all you need is just to check the ECG that is given and now be like, okay, what is the lead 1 there? What is the lead AVF? So really no battle. We know you love to fight, but don't go and be fighting with yourself there. Just look and don't be afraid to miss the question when you are practicing. You just check and just be like, lead 1 here, I think the QRS complex here is positive, the QRS complex here is negative, the QRS complex here is, you just look and just quickly draw this cycle and just be like, if it's positive like this, if it's negative, go. Don't go and, we have a way of drawing our positive and negative in the normal graph. So that's not like it here. So this is your positive. This is your positive for AVF. So this is your positive for lead 1. So take it like that. All right. So that being said, that's how you determine the axis. So the next question is, you get into the exam, they do not even ask you to calculate the axis or determine the axis. They are even the one mentioning the axis for you. They now ask you that what do you think is causing this? You see, this USMLE exam you are about to write, most of the answers will be in the question. So because most of the answers will be in the questions, you need to look well. But the problem is you might not even have that luxury of time to look well enough. That's why you need to practice and simplify things in your head. So for the left axis deviation, so you'll be seeing this in something that will make the left part of the heart to be very big, like left ventricular hypertrophy. So the heart will now be tilting towards that side. So for the right axis deviation, you will be thinking towards right ventricular hypertrophy. So the heart will be tilting towards the right. Can you see? So at least you've mastered one or two things there. Another thing is left anterior hemi block. You don't need to cram most stuff. So left posterior hemi block for the right axis deviation and lights. All right, so that's just by the way how you determine the axis. So that's it here. This is what I was trying to show you. So you can see the lead one, you can see the AVF. So this is the normal QRS axis. Look at it like that. So you now check, is it negative, is it positive, and the likes. So the next thing I want you to determine here is about the arrangement of the leads. We have what we call the inferior leads. So when you are looking at these leads, they look at the inferior part of the heart. That's what it means. While the leads that are on the right, they look at the right part of the heart. That's what it means. Then we have what we call the posterior leads. So just for you to have an idea, we also have posterior lead. Now look at this inferior part of the heart here. Can you see? Lead 2, 3, and AVF. So we used to say something, 2, 3, my foot. 2, 3, my foot. 2, 3, my foot. So when you get into the exam, they have given you the ECG. You now quickly check and be like, oh, I know that there is something called ST segment elevation. If I have the opportunity to show you, I will still show you. Maybe if I thought I get there. So there is something called ST segment elevation or depression or whatsoever, or just ST changes. But I'm seeing most of these changes in lead 2, lead 3, lead AVF. Immediately I see that, I will just say that most likely the patient is having inferior MI, because these 3 leads, they look at the inferior part of the heart. So I will just be saying inferior MI. Can you see? It's very easy. So which means when I look at the lead 1 and AVL, they will not really show significant changes. They are even most likely going to be okay. So if I look at lead AVR, also most likely to be okay. All right. So can you see the way you look at it? Lead 2, lead 3, AVF, 2, 3, my foot. Can you see? All right. So now what about AVL and lead 1? They look at the left part of the heart. Left part of the heart. So when you see a change, ST change in AVL and lead 1, you'll be thinking towards maybe MI of the left part of the heart or something like that. Just something related to the left anyways. All right. Now, what else do I want you to see? Is actually about this AVR. I want you to open your eyes and wake up. I want you to open your eyes and wake up and gain something here. Now, what I want you to see here is this. You see, God is so wonderful. This is how the wave of depolarization, this is how the wave actually travels. Just something like this. That's why we call this normal axis of the heart. So this is how the wave of depolarization will travel. So if this wave of depolarization is moving towards the leads, like in the direction of those leads, you are most likely going to see the QRS complex being positive in them. So whereas, look at this bastard here. Can you see AVR? AVR is a bastard. The wave of depolarization is moving away from AVR. What does that tell you? Out of all the leads, when you get into the exam and you see QRS complex in AVR, it must be negative by all means. 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 So when you see AVR, QRS complex in it and it's negative, before you start pressing the red button and start shouting for help, you actually expect it to be negative. You are not surprised. It must be negative. Can you see? That's one thing so before you start saying the patient is having something. So please focus on this very, very well. So sometimes what some people do is that They just, even if they want to determine the normal axis of the heart, they want to see if at all the wave of depolarization is traveling the way it should travel, they just go to the AVR and check. What is that AVR? And just say AVR, the QRS complex in it is negative, and they're okay, that makes sense. They actually expect it to be negative. That's another point I want you to pick here, so that when you are reading the ECG, you are not shouting for help even before you discover there is nothing there. Okay, so that's about that. Then you come down to the interval. So what about the interval? So there are two intervals you are going to take into this exam. So the first one is what we call the PR interval. So the first one is what you call the PR interval. PR interval. They will actually mention it. They will show you in the graph. Anyhow, they will actually bring them out for you. All right. So you can also try to check for ECG and bring out all this stuff so I don't waste your time. So PR interval. Now, the normal PR interval should actually be 3 to 5 small boxes. So when you draw it like this and you look for everything, it should actually be 3 to 5. This is your P wave. Do you get it? You bring everything together like this. So you should be getting 3 to 5 small boxes. 3 to 5 small boxes. 3 to 5 small boxes. So when you look at all the small boxes you are going to see within this region, it should be 3 to 5 small boxes. All right. So if you now get into the exam, they show you that this is what they are showing you. The thing is now very long. So in this regard, you are talking about prolonged PR interval. That's what it means. Prolonged PR interval. So if it's very short, so you are talking about shortened PR interval. Okay. Now that I know, it should just be 3 to 5 small boxes anyway. And don't forget that each box, small box is actually 40 milliseconds. So that's why you got 120 to 200 milliseconds. So for the prolonged one, we'll be looking at this first degree heart block, just heart block generally, and it's coming from usually from delayed atrioventricular conduction, heavy node conduction. I will show you everything today. I will get there today. So just relax. So it's prolonged. So you just see it's widened. And sometimes they don't really make reference to any ECG. They will just give you that the PR interval is 280, it's 250, it's 2 something. So just look at this number you are giving me is more than 200. So it's prolonged. Most likely I'm dealing with heavy block or something like that. So if it's shortened, the condition you will be thinking about is what we call the Wolff-Parkinson-White syndrome. I love to tell you, for those that are used to us, that the exam is not a syndromic exam. So which means that you are not really expected to be cramming syndromes. However, there are some syndromes that they will just test them. They won't be saying them that this is what we are testing, but they will test them. One of them is Wolff-Parkinson-White syndrome. So it's one of the commonest condition in cardio that you must never forget for the exam. So when it's shortened, Wolff-Parkinson-White syndrome. When you see a Wolff, you shorten your reaction time. Immediately you want to just run away, fly off. Do you get it? So that's short PR interval, Wolff-Parkinson-White syndrome. So what about the QRS interval? So QRS interval. So when you look at the QRS, all right. So when you look at the QRS, normally it should be less than 120 milliseconds. So something like this. So you just check it. What you are supposed to see here shouldn't be up to 3. That's what it means. 3 small boxes. So QRS. So permit me to just show you like this. So you check it shouldn't be up to 3. But when you check, you realize that it is actually maybe widened. When you start seeing it widened, maybe you are seeing something like this, the QRS complex. Don't worry, I will still show you more so you'll see them. So you'll be thinking towards widened QRS complex. You usually see that around, ventricular conduction defect. Do you get it? Ventricular conduction defect. I will show you everything when we get there. So this is just, we are still in the foundation. So ventricular conduction defect. So that's what you are going to see. So most QRS complex, you usually see them, they are narrowed like this. Can you see? Just small. So, but when you see it widened like this, just a ventricular conduction defect. So there is something about the ventricle. That's what it means. So what are those things that you can have within the ventricles, the conduction defects you can have in the ventricles? Number one is what we call left bundle branch block. Because when you draw your heart like this, when you draw the heart like this, don't say anything that, Professor, is this how your heart is? So this is the region for the atria. This is the region for the ventricles. So within this region, you now have the bundle branch for the conduction system. You have the left, you have the right. Permit me to just show you like this. You have the right, you have the left. So in a situation where one of them is blocked, so what it means, let us assume that the left one is blocked. So what it means that the wave of depolarization will first of all travel to the right, and now from the right is now going to escape to the left. So something that should have taken maybe 80 milliseconds for depolarization of the ventricles to occur if two of them are working together perfectly well. So but because there is a blockage with one of them, so one is now the one that is responsible for the entire depolarization of the ventricles. So that will make the timing to be prolonged. So when you see widened QRS complex, so one of the things you are most likely going to see, I may be thinking about is, am I dealing with left bundle branch block, or I'm dealing with right bundle branch block? Can you see? Left bundle branch block or right bundle branch, because the ventricular depolarization is what usually give you the QRS complex. All right, Festus, are you still awake? Are you there?
Yes, sir.
All right, good one. So I think it's only one person that is awake. Others, you are.
We are
Yes,
awake.
sir.
Others are like, just continue and let us breathe. All right. So that's for the QRS complex. Now, the next thing about the exam is this left bundle branch block. You're not like, yeah, I'm about to enter for exam tomorrow and I've mastered my QRS interval and the likes, and I have a way of looking at it. When I get into the exam, I don't want it to be widened. You see, you don't want it to be widened. No, it must not be widened. Once it is widened, there is a problem going on. What else is about left bundle branch block? Now, you must never enter into this exam and leave left bundle branch block in your bag. It's not allowed. When you become professor, you also will not allow it. You must never forget. Now, let me show you something peculiar about this LBB, left bundle branch block, and right bundle branch block. All right. So any question you read anywhere, whether African exam, Canadian exam, American exam, UK exam, I don't care, you see them mention that, okay, they do ECG and there is a new left bundle branch block. They are picking it. I will show you how you pick it. So just know that it's pathologic. It's what? Pathologic. And it may suggest something to you. And that is acute MI. Wait there. What does that mean? United States Medical Licensing Exam, we peg it on this. They will just mention that, yeah, a new left bundle branch block is discovered or something on the ECG. What is the diagnosis? What is the most likely diagnosis? Just flip through the option and pick MI. They are like, ow. They are not the same. It's just a block. But you are picking in fashion. Why? Because it is difficult to separate them. In a way, That block you are seeing, it is in a way difficult to be able to stick out your neck. For those that have long neck, to stick out, because those that have short neck cannot stick anything out. So to stick out your neck and be like, this is truly left bundle branch block, or and not MI, or is truly MI and not left bundle branch block, it is in a way difficult. So when you are looking at that patient and you are like, no, this is nothing, or it's just a block, it might just be an acute MI that you need to act on, because before you know, the patient may die. So one of the things you must never forget, write it down and put Festus' name at the front, that in my entire practice, in my career, I will not forget this fact. Anytime I read ECG and they mention that left bundle branch block and the physician is saying nothing to worry about, that I will worry in a way until proven otherwise. So it may be suggestive of acute MI. So anytime you read question, you see this, just be like, are you sure that is not MI? It's a fact. You are not negotiating it. Wait. So anytime we are now seeing a left bundle branch, we should just be shouting MI. For the purpose of the exam, if you don't really like too much headache, pick it like that, and you will see it play out in the exam. You will remember this day and be happy. You will just pick the answer easily and be chewing orogbo in the exam. Now, there is a way we now, they actually brought out a criteria that we are using to diagnose MI. Anytime we see left bundle branch block, we now want to be like, this is truly MI. This is not MI. This is MI. This is not MI. What is that criteria? We call it Smith modified Garbosa criteria. We know you hate names, because even the names of your neighbors, you don't know that is it Smith, you will know. This is Smith modified Garbosa criteria. So you must note it. So they will not mention Smith modified Garbosa criteria in the exam. They won't mention it. But they will give you the ECG or something that you can actually just look at and be like, this is actually MI, truly. This is not MI. Do you get me? But usually they stay at the peripheral level, where they will just tell you that left bundle branch block, what do you want to be thinking about? That's usually where they stay. They don't even really go deeper into the Smith modified Garbosa criteria. They call this modify because there was initial criteria before, then we needed to modify it, though I was not there. So that modification I will show you now. So let me show you what Smith modified Garbosa criteria is. I pray this actually opens. Oh, good. So this is the original Garbosa criteria. Can you see the original Garbosa criteria? Can you see? Now, Festus, show us why they link left bundle branch block and MI together. Okay. Now, the reason is this. In MI, we usually talk about ST elevation, non-ST elevation MI. So in left bundle branch block 2, you also have some ST changes. The ST elevation, you also see ST elevation there. You can even see ST depression there too. Which means that if they give you ECG and you are just seeing ST elevation, you will have been shouting MI before you realize that it's not actually MI. But it's better for you to say it's MI than for it to be MI and you say it is not MI. Can you see this ST elevation here? If you see it on normal ECG, you'll just be like, this is MI. This is MI. Whereas it might not actually be MI. But the reason why you have been doing so well so far is because it's better for you to prevent something that is dangerous, very, very dangerous, than something that is not too dangerous. That's why you have been scaling through. But when you get into this exam, you see ST elevation, ST depression. You can see ST depression here. Can you see? So that's the reason why when you see left bundle branch block, is in a way difficult for you to say, is it purely left bundle branch block, or I'm dealing with hemi. All right. So now, this is the original Garbosa criteria. You will see a particular part of the name. They call it concordant. You will see another part of the name. You call it discordant. So when you look at the QRS complex, can you see? You will now check, is the ST elevated? So if you realize that the ST segment is elevated and QRS complex is also what? Positive. So look at it, think about it. ST segment is elevated going upward. QRS is also going upward. Two of them are going in the same direction. You call that concordant. So you call it concordant ST segment elevation greater than 1 millimeter. So when you check it, you now, when you see ST segment elevation, you now check, is it more than 1 millimeter? They say it is more than 1 millimeter. Most likely, maybe I'm dealing with hemi. Do you get it? So look at this one. QRS complex. Can you see QRS complex is going downward? ST segment is depressed. Two of them are also going in the same direction. Depressed, downward. So you also call this concordant. So you call this concordant ST segment depression greater than 1 millimeter. Can you see? Now, wait. What are the leads that you need to focus on when you are looking at this depression and elevation? All right. So I will be thinking about elevation in all leads where the QRS complex is supposed to be positive. Think about it, my people. You now read your option. They now go and mention concordant ST segment elevation in AVR. Please tell me, do you think that will make sense?
No.
No. Because you don't even expect the QRS complex to be positive there. That answer, you cross it and leave the hall. Then you come here. There are some leads that usually you see their, what do you call it? You see their QRS complex being negative. Usually, what are those leads? Now, let me show you. Let me come here briefly and draw something for you. So, if you look at the art like this, this is the normal stuff. We have what we call the precordial leads. So, lead 1, lead 2, lead 3, lead 4, lead 5, lead 6. All right. So, and Festus was shouting the other time that this is the normal axis of the heart. This is how the wave of depolarization is moving. So what this means is that I can look at lead 3 and 4 that they are actually around the midline. I cancel them off. Remove lead 3, remove lead 4. I now focus on lead 1, 2, and lead 5, 6. This arrow, do you think this arrow is moving towards lead 1 and 2 or away from lead 1 and 2? Away. So because it's moving away from lead 1 and 2, what do you think the QRS complex here will look like? Negative. Whereas 5 and 6, it will be what? Positive. So when you look at that second criteria, and they are talking about concordant ST segment depression greater than 1 mm limited to. So the kind of lead you will see them making reference to here will be V1, V2. They now say plus or minus V3. So when it reach your turn, don't go and add V4 and V5, V6 to it. You can even remove V3. So this one will give you a robust understanding when you are reading a paper on all these MI and they are mentioning, and this also lead. It will make a lot of sense to you and be like, okay, this is the reason why you are focusing on this lead. Because the QRS complex here is actually supposed to be negative. So you cannot come here for this first one and be mentioning concordant ST segment elevation greater than 1 mm in lead V1 and V2. That would be wrong because you don't expect QRS complex to be positive in lead 1 and V1 and V2. That's the second. So come down to the third part of the criteria. You call it discordant. Discordant. Discordant ST segment elevation. So what I want to explain to you here is that what they call it discordant because the QRS complex is actually going downward. The ST segment is going upward. So they are moving in opposite direction. So you call that discordant. So this is the modified one. So they put an absolute value here for the original one, but they later removed the absolute value and now put it on they just put it on percentage. So it's still the same thing. Now, if you come here now, look at this. All right. Concordant ST segment elevation greater than 1 mm. Concordant ST segment depression greater than 1 mm. If you look at it, it's just 1 mm. Applicable in leads V1 to fix it. So, but when you are reading your question, you have an idea of the lead you want to quickly focus on. So you come down here, you see discordant ST segment elevation with ST to S ratio greater than 25%. Now let me explain this area to you so that when you get into the exam, they play around it, it will make sense. So now we understand the reason why this is discordant. You will now quickly come to the ST segment elevation. What is the value of the ST segment elevation here? So the value of ST segment elevation is actually from this isoelectric line. Can you see this isoelectric line, horizontal line? You
Yes.
now count how many small boxes you get up to this point. See my cursor.
Yeah.
Don't go to the peak. It must be this area where you start seeing, I don't know how to put it, but just interpret it. It's up to this joint. Do you get me? You count it. So that is going to be 4.0 mm divided by, you are now going to look for your Hz wave. Can you see? But you just look at it. So this is your Hz wave. What is it? You count how many small boxes. 10, 10, 10, 3.5. So making 13.5 mm. So you now put it in percentage. Once you get greater than 25%, then you are dealing with MI. So can you see? So when they give you that question, it's not difficult. So all you want to do is just to quickly check it, and they might even just give you something like, and just once you start seeing MI and they give you a wave, they are mentioning MI. What do you think this patient is having or something? And you now start seeing left bundle branch block in the option, or now see MI in the option. So what you now quickly do and be like, it's actually that Smith modified Garbosa criteria they want me to quickly apply. You now check the elevation I'm getting, is it more than 1 mm? And the QRS, so you focus on those leads. Those leads will be what they want to be using to confuse you. So it will be like, this lead they are mentioning in this option, is it actually supposed to have positive QRS complex? If it's not supposed to, and they go and link it to it, that would be wrong. So that's the criteria. All right, so they put it here for you. The first one, concordant ST elevation of at least 1 mm in at least one lead, just at least one lead. Why concordant, this one of V1 to V3 usually focus on that. Excessive discordant, can you see, in at least one lead with at least 1 mm ST elevation. All right, where excessive discordant is defined as ST elevation to the maximum QRS amplitude ratio of, I've already shown you how you look for the ratio, so you understand what to do. Good one. So that is Smith modified Garbosa criteria. So I don't have the intention of solving questions with you today. So they just to show you around how you think about it and see, for you to see the simplicity of the exam. So look here, a 58-year-old male with a history of hypertension present to you where you are wearing your gown or ward coat in the emergency department. So this patient is now having chest pain and shortness of breath. And the next nurse that has already hated you and is looking for a way to ridicule you, he's shouting, "Doctor, doctor, doctor, come here." You now see, where is this patient ECG? They say his ECG shows a left bundle branch block. That's what is there. And you just nod your head, and the nurse has. that which of the following is the most appropriate ECG finding to support the diagnosis of acute MI? And say, doctor, I have actually heard about left bundle branch block and acute MI. How are you sure this is not MI? Because the way you are nodding your head and smiling, it's like this patient does not really have something that bad. So how will you justify this? You now remember your Smith modified Garbosa criteria. They say ST elevation of at least 1 AM in lead 1. Do you think this really makes sense? What is wrong with this first option? What is wrong with the first option?
It should be more than or equal to
SDL.
So because V1 is not supposed to have positive what?
deflection.
Positive KRS. It's supposed to have negative. You remember the diagram I drew for you. So, and they are linking it to the ST elevation. So that's why you need to be very careful here. All right. So here, so another way they could have put this, had it been they are talking about the third portion of the criteria, they are linking it to the ratio, and you can be like, okay. But here they are just talking about ST elevation. So you can be linking it to ST depression. That's the understandable, like ST depression of at least 1 mm in lead V1, V2, V3. Those are the concordant stuff. But what they are mentioning here is discordant because the QRS complex in V1 is negative, not positive. And if I thought you will be linking it to discordant, you make reference to percentage. Do you get me? What is the percentage? What's the ratio in percentage? It must be more than 25% before you will say that this is actually acute MI. That's the third portion of the criteria. Can you see? I mean, at least 25%. So that's why this option A is wrong. Look at this option C. New or presumed new left bundle branch block with ST segment elevation of at least 1 AM in lead 2. Just something similar to option A. This is also what? Also wrong. Because in this one too, it's not supposed to be concordant. It's supposed to, it's not supposed to be discordant. It's also supposed to be what? Concordant. And QRS complex in Phi 2 is actually negative. So you should be making reference to ST segment depression, not elevation. Do you agree with me, everybody? Nobody agrees with me. Okay, now tell me where your confusion is coming from with respect to this question.
Where lead 2 is in the axis.
The what?
Where lead 2 is on the axis.
Where the Phi 2 is on the axis, right?
Yes, lead
okay.
2.
I drew something for you the other time. This is what I drew for you. This is the heart. Let's assume that this is the wave of the polarization traveling. So these are your precordial lead 1, 2, 3, 4, 5, 6. So if you look at it, precordial lead V1, V2, they are actually, the wave of depolarization is moving away from them, plus or minus lead 3. So the QRS complex in these 3 leads should actually be negative, not positive. And if I'm still going to make reference to concordant ST segment elevation, concordant ST segment elevation, it shows that the QRS complex must go in the same direction as the ST change. So if the ST change you are talking about is elevation in V1, can you see? In V1, then the QRS complex must also be positive. If the ST change they are talking about is negative in V1, then the QRS complex must also be negative. If the ST change they are talking about in V1 is depression, then the QRS complex must be negative. And normally speaking, if you look at what I've drawn here, the QRS complex in V1 and V2 will actually be negative. So it shows that for the concordance to be observed, they must go in the same direction. Do you get me? With respect to the ST depression, the QRS complex must be negative. So it will fit more into V1, V2, V3. That's why they actually specifically mention them. So when you now come to this option, They talk about ST elevation of at least 1 mm in lead V1. This will be what?
Wrong.
Wrong.
Be wrong.
Because
Yeah.
you don't expect VQRS complex to be what?
Positive.
Positive in lead V1. It's actually, so it's supposed to be negative. So that would be more of discordant. Do you
Yeah.
get it? If you come
Yes.
to option C, the same thing, ST segment elevation of at least in lead V2, that will also be wrong.
Yes.
Now look at option D. They say ST elevation of at least 5 mm in
That's wrong.
lead V1, in lead 1. In lead 1, ST elevation of at least 5 mm in lead 1. Do you think that really makes sense?
It should be one, more than one.
At least one. Do you get it? So at it being they just put at least 1 mm there, then that will have, because what we
Yeah.
are saying here is that if it is 4, you
It's
don't think
wrong. Yeah.
about acute MI. If it's 3, don't, so which is wrong. Look at
Yeah.
option B. ST depression of at least 1 mm in lead V3. Do you think this makes sense?
It makes sense.
Exactly. So that's why the answer is B.
Thank you.
All right. So that's how you will be looking at it when you get into the exam. Do you all agree with me? Do you understand this? Okay. It's only Dr. Flaky that understood what we've done. Dr. Benita, Dr. Sama, Dr. Osayani, are you sure you guys are still awake? Or you've taken a lot of... All right. So that's fine. So that's Smith modified Gabosa criteria. What about the right bundle branch block? How am I going to be looking at this? So permit me to just come down to this place so I don't bore you unnecessarily. Okay. I want you to look at this left bundle branch block illustration here. Good. All right, look at this. So see the QRS complex in V1, V2, V3. You can see if you look at the net QRS complex here, it's actually negative. If you look at this V3, it's already looking positive here and the likes. So check this left bundle branch block. Negative, 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 negative. So then you can see positive here, which actually makes sense. Now I want to check something out here. It is the QRS complex themselves. They are widened, 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 widened. I told you when you get into the exam, they give you the ECG. You now see those stores widened. So you start thinking towards, are you sure I'm not dealing with a block here? Check again. ST segment elevation, ST segment elevation, ST segment elevation, ST segment depression, ST segment depression. Can you see? Good one. So you start thinking, am I dealing with MI? Am I dealing with left bundle branch block? You now apply your Gabosa criteria. There is also one more thing I want you to note here. If I draw something like this, permit me to make this annotation. If I draw something like this, this is the heart. Lead 1, lead 2, 3, 4, 5, 6. And this is the wave of depolarization, the way it's traveling. All right. So if this is V, 1, 2, 3, 4, 5, 6. Out of this V1, V2, V3, V4, V5, V6, the ones that are actually related to the left part of the heart is actually, completely lead V5, lead V6. The ones that are more located or related to the right part of the heart will be V1, V2. Are you seeing what I'm saying? V1, V2. Do you all agree with me, everybody?
Yes, sir.
Good one. So The reason why
Yes.
I'm saying this is that there is also something you want to look out for in your exam. See this notching. Can you see this notching? Can you see this notching here? This one look like letter M. This one also look like letter M. Where will I be seeing letter M? You will be seeing it more with respect to the lateral part of these 6 leads. Lead V5, lead V6. No wonder. Or the left part of this lead V5, lead V6, and that is left bundle branch block. Can you make a guess where this kind of indentation is most likely going to be for for right bundle branch block? Make a guess.
V1, V2.
Do you all say V1, V2? V1. Okay, now let's check whether you are right. Because if you are right, all you just need to do is just to go and write your exam. You are okay already. So now let's check. Oh. See. Can you see what you are seeing here? Can you see what I'm seeing here, rather?
Yes.
Good. I'm coming. How come I can't? Okay, this should be here. All right. So see here. I'm seeing something here. I'm seeing something here too. What am I seeing?
M shape.
Can you see? Can you see? In lead V1, V2. So when you see this, you say right bundle branch block in V1, V2. But if I'm seeing it more on the something that look like that, which is not going to be this deep anyways, on the V5, V6, I'll be thinking more towards left bundle branch block. Can you see it's not even difficult at all? So have you ever seen the rabbit ear before? Let me show you rabbit here. I know you don't want to see anything, but I will still show you. Can you see the rabbit here? Can you see the rabbit here? Can you see this rabbit here? That's how it looks like. Can you see the rabbit here? Rabbit here. So that's the kind of picture you actually see here. Where is it? That's the kind of picture you see here. Rabbit here. So when you see that rabbit ear pattern, you'll be thinking more towards right. You see it rhyme. Right bundle branch block. Can you see? Rabbit here. Rabbit here. Rabbit here. No, don't go to the exam and be shouting tigers here. So it's actually rabbit here. Very simple. So left bundle branch block, you shouldn't miss it. So you'll be seeing that indentation on the V5, V6. While for the right bundle branch block, you'll be seeing the indentation more around the V1, V2. So that's that. Very easy and straightforward. So you come down to the QT interval. So now, with respect to QT interval, what do you want to take into the exam? What is the normal QT? There is what we call corrected QT. So that corrected QT is what you are most likely going to be giving. So I will advise you to, if it's going to be by cram it, rehearse it. What's the normal QT interval? That is 380 to 440. 380 to 440. So because what USMLE will do basically is to give you a value. They can say that the QTC is 460. Immediately you see 460, you already know it's prolonged. Immediately you see 450, you know it's prolonged. Immediately you see 445, you know it's prolonged. But if you see 420, you know it's normal. So if you are not very careful, they will quote a figure for you, but you will not know how to interpret it. You will now be saying, I don't even know what this question. So I highlighted it for you because you must know it. It's a must know. All right. So you'll be thinking towards prolonged QT interval when it's now greater than 440. If they like, they should give you 442. You say it's prolonged. So now, when I see it prolonged, what will I be thinking about? What you'll be thinking about is what we call, there are two sets of conditions. Am I dealing with acquired prolonged QT, or I'm dealing with congenital prolonged QT syndrome? Can you see the two of them? Is it acquired or congenital? So quickly check the age of the patient. So if you check the age of the patient and this patient is maybe a middle age, old or something, most likely you are dealing with acquired. Check that question again. They will have given you a premise for it. Is this patient recently being treated with something? So because you might be dealing with a drug that is causing it. They might say the patient is recently, is receiving treatment for urinary tract infection. The patient was recently treated for pneumonia. The patient is having cancer, is receiving chemotherapy, and the patient was given ondansetron. They might not even mention the name of the drug. They might just say the patient is recently being treated. They now notice this prolonged QT. Maybe the patient is maybe feeling dizzy or the patient is collapsing in a way. So when you see that, there is a premise. You can be logical in your thinking, but you are not really that sure. You just know that I know there is prolonged QT here, but I don't know what is causing it. And you see a drug there, it might actually be that drug. You are doing a practice, you are already in the clinical practice. This patient is using a particular new set of a drug that has never been in a system, but recently maybe just brought to the hospital. But this patient is presenting with maybe loss of consciousness. Why are you losing consciousness? In a way, you do ECG, you now see prolonged QT when this patient is on this drug. But out of all the drugs you have known, that drug is not part of it. You are not saying that this drug is causing it, but there may be a correlation. There may be a correlation is not causation. It's not causation, but there is a link. It doesn't mean it's the one causing it, but there is a link. You can now try to do a further study and be like, this new set of drugs is actually causing prolonged QT interval. And that's how you look at it. So when you get into the exam, they will give you a drug. For smart people, they don't even care about, they will just be like, most likely it's just the medication effect, adverse effect. You just pick medication adverse effect. But if they are specific enough, that becomes a trap for you because you don't know which one to pick. But by the time you practice some questions enough, you will be able to remember. So what are these common drugs that usually cause it? Macrolide, like erythromycin and the likes. So you just see them, just tell you the patient is using one of those drugs. Fluoroquinolone, ciprofloxacin, levofloxacin, moxigati, and the likes. Floxacin. Opioid. This patient might actually be a young guy that has been abusing opioid, but you don't know. You just see this patient is having prolonged QT and you are shouting, we don't know. What of you this patient is abusing a drug at home? So this patient, are you on any drug? It might even be ondansetron. This patient has been vomiting, having a particular, maybe sharp vomiting, maybe on cancer, on just vomiting, and he's taking the antiemetic drug. And this patient is now developing this prolonged QT. So you'll be thinking towards that drug. So that's how, what they want to test is your ability to know that. Do you even know what can cause this before you start shouting it is Owaye? No. So will you be able to investigate that? All right, so that's that. Other things can be electrolyte derangement. Now, the question is, what condition can now make the patient to be having electrolyte derangement? You have hypokalemia, hypocalcemia, hypomagnesemia. Now, let us think. What do you think can make a patient to have hypokalemia? Think about it.
Diuretic.
Diuretic number one.
Vomiting.
Vomiting. Maybe some people are even still having diarrhea. So you are not mentioning that. So don't forget diarrhea. It might just be a diarrhea that the patient is having. So you don't know which electrolyte, but you just know this patient is maybe having one thing or the other, removing excessive fluid, is losing fluid and the like. Most likely the patient will become electrolyte deranged. So it cannot be any of these guys. What do you think can cause hypomagnesemia? Anybody? Hypomagnesemia.
Alcoholism.
Alcohol abuse. So you imagine that this patient is just taking alcohol, has been taking, is actually an abuser of alcohol, but you don't know. This person just say, I just take alcohol very well. Maybe you don't even ask, but you realize that the QT is prolonged. So this might actually be the cause. Do you get it? So never forget this. So that's how the question will go. And there are some antiarrhythmic drugs also that can actually prolong QT. So class 1A quinidine, procainamide, class 3 sotalol, amiodarone, and the like. So that's for the acquired. So let us look at the congenital. So likely the patient here will be young. So very young patients. So likely, most likely. So that's what you see here. So there is something you must always look out for. It must be there. It will be there. It will be there. It will be there. It will be mentioned. People are saying, first of all, just say it and get out. I need to add emphasis on that, so that when you get into the exam, you do not lose focus. And that thing is deafness. Any QT interval you see them mentioned, and they hard to hit. These patients, maybe anyhow they want to put it, not responding to call. Maybe the patient is deaf. Deafness. You will be thinking towards congenital long QT syndrome. Likely. Which of them? There are two. The one that you usually see deafness there, that the patient will present with deafness. What kind of deafness? Sensorineural, not conductive. Sensorineural is what you call Jaffel and Lange-Nielsen syndrome. The other one where you will not see deafness is what you call Romano-Ward syndrome. You can look at it and say, I hear a word. Then the patient is not deaf. The patient is saying, I can't hear a word. Then the patient is deaf. I hear a word. You can hear what? The patient is not deaf. You can hear what? In Romano word. Don't go and look at it and say no word. It's Romano word. I can hear a word. The patient is not deaf. You can hear something. You can hear a word. I can't hear a word. Then likely the patient is deaf. With prolonged QT, you be thinking towards congenital. And that's that. Very easy. Let me show you a question, just for you to have an idea of how this could play out. All right. Look at this question. 62-year-old man is brought to you because of an episode of syncope 2 hours ago. They just have that syncope stuff. So he reports sudden onset of palpitation, followed by loss of consciousness while carrying his groceries to his car. You are like, what are you can't even really place your finger on what's going on. And I say, he is unable to recall any further details and does not have any chest pain or dizziness. He has a history of hypertension, type 2 DM, gastroparesis, osteoarthritis of the knee. Medication include lisinopril, metformin, ondansetron as needed for nausea. He also takes methadone for chronic pain. Apart from an abrasion on his forehead, he appears well. His temperature is fine. Pulse is high. Regular. Blood pressure is 135/70. While he is in the emergency department, he loses consciousness again. Doctor! Oh, people are like, Festus, we don't shout like this. You just press a bell. Okay, they press the bell. They call you. They have already called you and be like, doctor, you need to attend to your patient. You are there with your stethoscope hanging around your neck. You now say, telemetry shows polymorphic ventricular tachycardia with cyclic alteration of the QRS axis and spontaneously resolves after 30 seconds. You call that torsade de pointes. You now say, result of a complete blood count, serum electrolyte concentration, and serum thyroid study show no abnormality. Everything is okay. Because immediately you got there, the first thing you asked for was, Nurse Lagbaja, where is the electrolyte of this patient? Because this thing, ECG is showing torsade de pointes. So where is the electrolyte profile. You just bring it, say everything is okay. Okay, that's fine. What about the medication? You want to now ask, what are the drugs we have placed this patient on? They now list all the drugs for you. So when you see, you now quickly flip through all the drugs and be like, this patient is on lisinopril, is on metformin, is on ondansetron, is also on methadone, and a 62-year-old. So you're already thinking towards something. You see, result of a complete blood count, serum electrolytes, okay. Cardiac enzyme are within normal limits. Which of the following is the most likely underlying cause of this syncope? So what do you think this patient is having?
Prolonged QT.
That's wrong.
Oh, that's at the point.
That's wrong.
Wow.
What is your answer? Don't look at the option. Forget about the option. Look at this patient. What's your diagnosis? How will you have written your diagnosis? You are the doctor.
Prolonged QT interval secondary to medication use.
Dr. Benita, receive your prize. You say acquired prolonged QT. Do you get me? Secondary to which medication? You now say bracket. What are those medications?
Ondansetron.
Ondansetron and methadone.
Methadone. So what do you want to do for this patient here now? What will you have done? What is your plan?
We check if it's stable.
The patient is stable because the thing just comes and goes.
Maxo.
Mag. So apart from that, what else do you want to do for this patient?
Discontinue the medication.
You need to review. You say medication review. You review the patient. That's just what I'm looking for. You review this patient's medication. Do you see the way you are looking at your thing? So that when you get there, the way you think must actually really make a lot of sense. Because if you just say, oh, this patient is having prolonged QT, it doesn't still make too much sense because you've not really communicated anything. Now say this is acquired prolonged QT, secondary to medication effect. Bracket, methadone, ondansetron. Do you get me? Plan, review, medication. So you can, maybe you are the one on call. You need to actually just, for now, they need to hold these two medication. They need to hold them. You just say hold. Then you expect the physician, whoever that is treating the patient, to review the medication later. That's all. Very simple and straightforward. You see the way you look at it. So let me show you another one. So look at this one. Let us see what you bring out here. 25-year-old woman presents to the mind department after a syncopal episode while exercising. How come is when you are exercising you have a syncopal episode? Something is going on. You don't really know, but you have an idea. Now say she denies chest pain or palpitation, but mention a family history of heart problem and sudden death in her father at age 40. So if you look at it, you are seeing family history is there. ECG is also showing QTC of 520. Do you think this QTC is prolonged or not?
It's prolonged.
It's prolonged. All right. Now, which of the following is the most likely?
It's prolonged.
What do you think is likely going on here? What is your answer?
Congenital QT.
So most likely you are dealing with congenital because you can see a family portion of the whole this thing, something that has been running in the family. Do you get me? Because this is just 25-year-old. The patient is still relatively young. It could have been from drug. It could have been from anything, but you can't see any other thing that could be linked to drug. Maybe the patient is abusing drug or something, or is having a condition that could cause this prolonged QT. The only thing they are giving is a family history. Most likely is congenital. All right. So most likely you are dealing with long QT syndrome. Do you get it? So that's that. All right. So now you have an idea of how you'll be looking at it. So that's that. So you come down to the ischemia. Let me allow you to go for how many minutes break do you think you need?
10 minutes.
1 hour. Okay.
10
I actually
minutes.
thought you say 1 hour. I'm amazed. Thank you. Okay. All right. So now you come down to the ischemia, infarction, and the likes. So how do you want to? But before I go, there's something I think I need to mention here briefly. And the condition, what is actually going on in Jaffer and Lange-Nielsen syndrome. Now you have an idea of how you look at it. So they usually just have a defect in potassium channel conduction. All right, so that's one thing you must not forget. So a defect in potassium channel conduction. So and don't forget how you look at it, check for deafness and the likes. You won't really be able to peg it on anything. Then you can also check for the age of the patient is really going to help. So for the ischemia, some people will be like, I'm not used to looking at ECG and I just hate those ECG, possibly you've even sent consult for one ECG today and be like, go and give it to Dr. Lagbaja, whereas you are preparing for the exam. So we are not saying this for you to change your way of doing things there, but just for you to see the simplicity of the exam, not the complexity of your practice. So when you get into the exam, they will give you the ECG. All right. Or they mention some stuff. What you want to quickly check for is what you call the Q wave. You check for Q wave in that question. So any question you read and you see them mention something like Q wave, tentatively you can actually just be like, okay, is this just only Q wave, or the Q wave is occurring with some ST changes, or there is a preceding history of something I can actually peg on MI and the likes. So look out for that Q wave. So look at this area now. See what I did there? I just put a line here to define all these, their changes, their ECG changes over time to 2 sessions. So I divide it like this. I'm seeing Q wave here. This Q wave is just appearing. I'm seeing Q wave here. I'm seeing Q wave here. I'm seeing Q wave here. So when you see Q wave, you can actually just more or less be like, in this exam, most likely something is going on. Do you get me? Most likely something is going on. Either something recent or something prior, or it has occurred before and the patient is now okay. So the next thing you will do is to check for what you call the ST elevation. ST elevation. So when you look here, you are seeing some ST changes here. ST change. What you actually have is more or less like T wave inversion. You can see T wave inversion here. You can see some ST changes. But when you come down to this place, you are not seeing the elevation again. You are not seeing the elevation again, but you are still seeing that prominent Q wave. So, and you call that Q wave prominent when it is more than 40 milliseconds. Can you see? 40 milliseconds. Never forget it. Or the amplitude of it, how deep it is more than 1/3 of the QRS. So look at it here. This is the QRS. Let's assume that the total number of small boxes you have here is 9. Small box is 9. You now check the Q wave. You now realize that the Q wave is deep by 4 small boxes. That's already more than 1/3. So you call that pathologic Q wave. It shows that there is a pathology. It's not just ordinary Q wave again. Do you see the way you are looking at it? So don't forget what you check for, Q wave. You now need to know, is this just a physiologic Q wave or pathologic Q wave? So you'll be thinking towards pathologic Q wave if it's very wide, it's more than 40 milliseconds in width, in duration. Do you get it? In length? You can look at it like that, in length. So which is more than 1 small box, or is deep, very prominently deep. And how do you be able to judge that? You compare it with the QRS complex and be like, what is the depth compared to the QRS height, the amplitude? That's how you look at it. Once it's more than 1/3 of it, then it becomes pathologic. So it shows that it's either this patient is recently having MI, or the patient already suffered it before. So how will I be able to separate them? I will now check for ST segment changes. So if I can see ST segment changes, most likely I'm dealing with something recent. So if I can't see, most likely I'm dealing with something that occurred a long time ago. You can also look at the T wave. So when you get into the exam, That is how you look at it. Let me see what we have here. So look at this question here. 65-year-old man present to the mind department with acute onset chest pain radiating to his left arm. So an ECG reveals ST segment elevation in lead 2, 3, and AVL, which is inferior lead. So you're already thinking towards inferior MI. They now say 6 weeks later, a follow-up ECG shows deep Q wave in the same leads with no ST elevation. So immediately you see this. See the way they qualify the Q wave. They say it's deep. That makes it pathologic. So it's not just ordinary. Again, it's not just physiologic. So that becomes pathologic. It's very deep. So what is the most likely explanation for this? So you'll be thinking towards previous, because if you check it, you can't see any ST segment changes. It's not something recent again. Do you get me? It's not something recent again. So it is now past. It's like the patient is now more or less like stable. That's how you look at it. The patient is now a stable patient. So whatsoever you are seeing there is coming from the previous MI. So that is why the answer is myocardial scar formation. Now let me now rephrase it for you so you understand. They give you this same scenario. Okay, before I go, do you understand what I just explained now, everybody? Do you understand? Okay.
Yes.
Lovely. So now let me rephrase it for you. They say a follow-up ECG shows deep Q wave in the same leads with ST segment elevation. Immediately you see with ST segment elevation, what will you now be thinking about?
He had another MI.
Good
Acute
one.
MI.
The patient has already developed another one. You see the way you are looking at it. That is the concept. That's how you look at it when you get into the exam. So you do not want to, when you see them mention Q wave in the exam, you want to quickly start peeping and be like, what is the ST elevation pattern, T wave pattern in this patient? Once they are adding a ST segment elevation, is also, is also there. Even if the patient suffered it 4 weeks, 6 weeks ago, and the patient is still having those ST changes, then likely the patient has suffered another one. Do you get it? So you will know how to approach the patient. Okay. All right. So you can go and try more questions around that. So that's just what I think I should. So never forget the significance of pathology Q waves in STEMI. So when you get into the exam, when they start mentioning it, don't forget. So usually make reference to it in STEMI. All right. Q wave signifies either acute or prior ischemic event. So you just want to check, are you symptomatic? Are you not symptomatic? Is there any ST changes? No ST. So you know how to do it. Non-Q wave, in fact, they're actually the one you see them linked to non-ST segment elevation MI. So non-Q wave. You don't make reference to Q wave in those ones. So you make reference to Q wave in STEMI, not in N STEMI. All right. There are some other changes that you can link to inversion. You have what we call poor R wave progression. Poor R wave progression. There is a way the R wave should be increasing. Do you get me? From V1 to V2 to V3 and the likes. So when you now check it, you realize that it's more or less like it is reversed. It's not progressingly increasing from V1 to V2 to V3 or something like that. So it's more or less like, so that's poor R wave progression. You can see that. I'll look out for that. All right, so I'll quickly come down to the chamber enlargement. So we have the atrial enlargement, we have the ventricular enlargement. So with respect to the atrial enlargement, just focus on your P wave alone. P wave for now, just focus on that. So we have the right atrial enlargement, we have the left atrial enlargement. So all you would do is to check the name, right, height. What you will see that we give it out is the height. So when you check for the P wave and it's more than 2.5 millimeter in height in lead 2, so you will say that it has gained height, right atrial enlargement. So when you check for the P wave and it has gained length, so it's now more than 3 milliseconds, 3 small boxes. So you'll be thinking towards left, not depth, length, left atrial enlargement. So you can see. So when you get into the exam, you just rehearse these two things. If it's height, that is more than 2.5 millimeter in height, I'll be thinking in height, I will be thinking towards right, atrial enlargement. If it's length, I'll be thinking towards left. All right. With respect to the ventricular enlargement, there are so many criteria that they usually give, but really, they don't really focus on them that much in the exam. So the advice I will just give, you can use this one, S wave in V1, then you combine it with what's the total amplitude of the R wave in V5. So if you are getting around 45 and above, you are thinking towards left ventricular hypertrophy. So I just put something like this, SIF reverse, like SV1, RV5. If that helps, you can use that. SIF first, reverse 5. I think after GR5, you have reverse. So you can use that one if you wish, for those that drive. So SIF first, reverse 5. SV1, reverse RV5. So when you are now getting, you add the S wave in V1 with the R wave in V5, you add them together, you are getting 45 and above left ventricular hypertrophy. You have so many criteria that you can also look at. There is another one, amplitude of S in V1, R in V5 or V6 if you are getting greater than 35 and the like. So but the exam is not really about these guys. There is a point you must not forget about the hypertrophy of this ventricle, and that is the hypertension is the most common cause. You must never forget hypertension. They call it silent killer for a reason, and that because hypertension can destroy so many things in the body: the eye, the brain, the artery, the kidney, even the heart. And the patient will not know. The patient will just say, I'm still okay, I'm fine, but they're actually being destroyed. The heart is shouting for help, but nobody is hearing his voice, all because it's hidden within the chest. So that's one thing you want to note, you want to look out for. Hypertension is the most common cause of this left ventricular hypertrophy. These are the other causes: aortic stenosis, regurgitation, and the like, but don't forget hypertension. So for all you care, when you get into the exam, they will just give you what is the most likely cause. Once you see that your answer is just hypertension, please don't go and be negotiating what is not right. All right, so that's that about this. The same thing for right ventricular hypertrophy. So what you have there, R wave in V1. So you don't need to cram this. If you can't really pick, they hardly test these ones. But once you see it, you will know that, okay, this is a cause. So right heart is supposed to pump blood towards the lungs. So let's assume that something is going on in the lung. So right heart will now be pumping against resistance. So like pulmonary hypertension. So those vessels within the lung, they are narrowed. So there will be pulmonary hypertension. So the right heart will now be pumping against that high resistance, and that will cause right ventricular hypertrophy. What if you have a big clot that is blocking those vessels? So the right heart is pumping against that big clot. That's going to raise the resistance too. So the next thing is right ventricular hypertrophy. The same thing for chronic lung disease. So the next, you see vasoconstriction coming from all those hypoxia and the likes. So that will raise we cause the pulmonary hypertension, and the next thing you see is the right heart pumping against high resistance. So in tetralogy of Fallot, you have pulmonary stenosis. Right heart will also be pumping against that high resistance. So they are the things you can easily look and understand. So when you see a question on it, you can easily be like, this thing will cause right ventricular hypertrophy. So they are not something you see there and start listing and start cramming. All right. So I put something here. I just say easy. You can, if I thought you want to master this, you can master it, but you don't need to cram it. So that's that about all those ones. So let's come down to the next part of our study. You call it cardiac physical exam. So I will show you what is important, what you want to take into the exam or notes. This is highly significant with respect to your success in the cardiology questions, because there is no way they will set a question or write a question that most of the time you won't see them put some physical findings there. So unless they just want to be intentional about where they are going and they just want to ignore it, because you will click that patient and also bring out some physical findings. So the first thing here is about jugular venous distension in the exam. You call it JVD. So this is how you look at JVD. Assume that this is the heart. This is the heart. This is the right part of the heart. This is the left part of the heart. I'm going to just show you like this. You now have like a jugular vein that is supposed to empty into it here. So what this means is that it's supposed to empty into the right atrium. So what this means is that if the blood in the right atrium is not going forward by any reason, the blood in the jugular vein will not be able to empty. Will not be emptied. If it's not emptied, the jugular vein will now appear distended. So what it means is that when you read any question, and the question now mentioned that the jugular vein is distended, likely the right atrium is blocked. Maybe you are dealing with tricuspid stenosis, or you are dealing with right heart failure. The right heart cannot pump out the blood in it, or you are dealing with pulmonary stenosis. You are dealing with pulmonary hypertension. Anything that we shall not make the blood within the right heart to move forward, that will cause jugular vein distension. Very easy. So now you are a newly matched resident. You are doing ward round. In fact, your ward coat is the neatest, well ironed, with your name well branded on it. Your first posting, whatsoever you are doing, you are seeing a patient in cardiology unit, and you look at this patient. You look at this patient, you nod your head, and whatsoever your supervisor is asking you that, Dr. Lagbaja, the way you are nodding your head is like you have treated this patient completely in your head. What can you see? I now say, I can actually see the jugular vein of this patient. Can you turn? Is it as it's well distended? Now that you are seeing it distended, what are you thinking about? You just need to start from here and just be going up. It could be maybe something about the tricuspid valve is maybe stenosis or right heart failure, or I'm dealing with pulmonary hypertension or pulmonary stenosis, or I'm dealing with this, I'm dealing with that. It can even be from congestive heart failure, both sides of the heart. You just keep naming them and it becomes very easy. So that's that. All right, the next one is hepatojugular reflux. So they will mention hepatojugular reflux in the exam. There is a way you do it. So I want you to look at the name. The name here is hepatojugular. So there is something related to the liver and there is something related to the jugular, the same jugular vein. All right, so let's assume the same diagram here. Let me now put a liver here. All right, it's a physical exam. You've seen this patient. In fact, immediately you see this patient, you are shouting, "Get me glove." They get you glove. The nurse quickly just get you glove. They just throw the glove at you. So within 2-3 seconds, you've already won the glove and you are shouting, please screen the patient. So they screen the patient for you. You carefully introduce yourself and say, I'm here to actually check something here. All right, what will you be doing? With the abdomen well exposed, you are not going to palpate. You palpate like you press it towards the liver. It's more or less like you are just moving blood towards the liver, or you press the liver. All right. So when you apply pressure to this liver, if at all, whatsoever the patient is having, what you are going to do is that when you apply that pressure, you watch the neck of the patient. So now, which scenario are they going to link it to? You are seeing a patient with pida edema. Pida edema. Immediately you see pida edema, you ask yourself a question. Is this pida edema coming from heart failure, or is coming from liver cirrhosis. Think about it. If you are dealing with liver cirrhosis, the patient will have beta edema. If you are dealing with heart failure, like right heart failure, the patient will also have liver edema. Now, the question is, how will you be able to separate the two? This is just, the patient has not done any investigation about the liver, you are just seeing the patient for the first time. You need to examine the patient carefully and bring out your diagnosis. So that question will now bring out what you call hepatojugular reflux. So think about it. You have applied the pressure. If the liver is cirrhosed, you will not see, when you apply that pressure, you will not see anything with respect to the jugular vein distension, because the pressure you are applying will not squeeze anything out of the liver, because the liver is cirrhosed. There is nothing that will squeeze. You will not see any change in the jugular vein distension. You won't see it. You will not see it. You will not see it. But if you apply that pressure to the liver and you realize that as you put it, the jugular vein just become distended, you release it, it's reduced. You apply the pressure, it's become distended. It shows that the problem is from the heart. It shows the blood is not going forward from the heart. The problem is not from the liver, not likely. That's how you judge it. So when you read the question and they say that the hepatojugular reflux is done, if they say it's done, the next thing you want to ask yourself is, what is the result? When you apply the pressure, does the jugular vein become distended? If they say it's become distended, likely you are dealing with the heart problem. If with all the palpation, with all the pressure, you are not, pressure I wanted to say not palpation, with all the pressure, you are not seeing anything with respect to the jugular vein, likely the problem is from the liver is cirrhotic, is cirrhosed. So with that, you will not see the pressure transmission, and that's that. How many people, did you understand what I just explained? Hope you've gotten my explanation. All right, good.
Yes.
Good. So you understand the way you look at it. So the next one is what we call the Kussmaul sign. Kussmaul sign. Kussmaul sign. Kussmaul sign. Kussmaul sign. Kussmaul sign. So what is going on in Kussmaul sign? All right. Normally, this Kussmaul sign is related to inspiration. All right? It's related to inspiration. So when you inspire, this is the lung. This is the lung. When you bring in air, you also at the same time bring in blood for oxygenation. What that means is that when you are breathing in air, you expect more blood to come to the right part of the heart. When you are bringing in air, you expect more blood to come to the right part of the heart, and you expect that blood to go towards the lung, which means the blood is actually going forward. That is normal thing that occurs. So if blood is continuously going forward, is going towards the lung with inspiration, I'm not supposed to see any blood being left behind within the jugular vein. That is normal. So when you say you are breathing, you are even supposed to see the blood in the jugular vein being emptied. Everyone goes towards the lung for oxygenation. I'm talking about the blood. But in this patient, you realize that breathing, the blood, you now see the jugular vein becoming distended. The question is, wait, why are you not going towards the lung? Most likely there is a problem. It's either the heart is not accommodating all the blood moving towards the heart, cannot accommodate it. Why can't the heart accommodate the blood coming towards the right heart? Maybe the heart cannot distend on its own. What can make heart not being able to distend? Maybe we are dealing with what we call constrictive pericarditis. Now, Festus, what are you trying to say? What I'm trying to say is that in this exam you want to write, when you get there and you see them mention Kussmaul sign is positive. Kus, cons, cause constrictive pericarditis. So you don't need to overthink it. Once you see it, just be like, I don't know. You have 15, 20, 30 seconds left for that question, but you just flip through and God just take your eyes towards Kussmaul sign is positive. Just go towards the option and pick constrictive pericarditis, at least for the time being. You don't need to be correct, but that is a very good strategy. Constrictive pericarditis, you see a positive Kussmaul sign there. Now, you come down to this area, which is more or less like some valvular problems and also some valvular problems and some conditions that are just related to the heart. So the way I'm going to put it for you is this, and I want you to really pay attention to my approach. I know you know it. In fact, maybe we even have a cardiologist here. All right. So, but just for you to have a way of looking at it for the purpose of the exam. Now, when they give you, you see, when you are dealing with murmur, it's all about murmur. When you are dealing with murmur and the question says they do so something, and that thing they just did increase the blood flow through that particular valve, and that murmur increase, or increase blood flow through the heart or that particular side of the heart, and the murmur increase, you are dealing with a regular valvular problem. So we have regular valves like tricuspid valve, aortic valve, pulmonic valve, mitral valve. So if the problem is related to these regular valves, when they do anything that increases the blood flow through that particular valve, the murmur will increase. So if they do anything that reduces the blood flow through that valve, the murmur will reduce. Now relax, still relax, and now get into the exam. They mention a particular procedure or maneuver, and you look at that maneuver will increase the blood flow to the heart. And you check that question, the murmur increases. Just be thinking towards regular valve. That's all. That's the logic. That's the concept. So you ask a patient, stand up. You are there. They say, Doctor, let me pick a name. Doctor, okay, I'm going to pick Dr. Flaky. Dr. Flaky, the patient is here. You need to come and examine this patient. You know, I'll say, okay, I'm Dr. Flaky. Please, I would really love it. Please, can you, I'm examining you, I'm picking a murmur. You now ask the patient, stand up. Immediately you ask this patient, stand up, the blood flow to the heart is supposed to drop. And you check that murmur, and that murmur also reduces in intensity. Then definitely you are dealing with regular valve. So you will just flip through all the options and check which one is a regular valve problem here. If they just mention here and that valve is related to that side, that's going to be the answer. But the question says they do something to the patient, and that thing, you look at it, you realize that thing will increase or reduce the, let me still use reduce the blood flow towards the patient's heart. You know, the question now say during that time, the murmur becomes high in intensity. Then you will be thinking towards these two bastards, MVP or ACM. Now, can you see the way I'm looking at the question? No cramming. They will give you stories and the like. Now say murmur. So when you see that murmur, just ask. You are the one listening to the presentation. Just say, when you ask the patient to stand up, did the murmur increase in intensity? You say, yes. And now say, what are the two differential? Because you ask the patient to stand up and the murmur is in. Can you see? You are just looking at the arrow and be like, I ask the patient to stand up. The blood flow towards the heart will drop. And during that same time, the intensity of the murmur is increased. What are your true differentials? You be thinking, oh, maybe I'm dealing with MVP or ACM. But you ask the patient to stand up, and the patient's blood flow drops, and during that same time, the murmur intensity also reduces. You will be thinking more towards the regular valve problem. Good. Now that you have this basis, you come down to these maneuvers. So they will mention the maneuvers for you in the exam. Number one, squatting. I won't bore you with unnecessary jargons and likes, because we've already mentioned this in our. I just want to lay the foundation for you, then go and carry any question anywhere. Not only US related question, carry the one for UK, Canada, Nigeria, Ghana, anywhere, Australia. Just keep applying them and see how many of those questions you miss. So you check, you now say, you are saying this patient should squat. When you ask the patient to squat, squat, the patient is squeezing all the veins. So there will be, in a way, increase in venous return. So I now check, if there is increase in venous return, it shows that more blood is flowing through the heart. If the next thing I want to check in that question is, what happens to the murmur intensity? The question now says the murmur intensity also increases. Then, if this cutting is increasing venous return, where is the blood flowing through? You now say the right part of the heart, and the intensity of the murmur is also increasing. That I'll be thinking towards regular valve problem on that right part of the heart. Maybe I'm dealing with tricuspid problem. It can be a stenosis. So it can be anything. You check. You can also pick something like pulmonic stenosis, pulmonic problem, tricuspid problem. It's just as easy as that. All right, that is for this cutting. But the question says, when the patient squats, which will push blood towards the right part of the heart, you realize that the murmur reduces in intensity. Immediately you see that. How come the murmur is reducing in intensity? When I ask the patient to squat, they are moving in opposite direction. So you'll be thinking towards HCM, hypertrophic cardiomyopathy, or mitral valve prolapse. Do you see the way you are looking at it? The same thing for Fasava. But let me come to the leg raise for now. For the leg raise, this patient lie down, and you now ask the patient, raise your leg, or you passively raise the leg of the patient. So when you raise the leg of the patient, it's like you are favoring venous return towards the heart. So there will be increase in venous. You now check that question, what happens to the intensity of the murmur? Then I say the intensity of the murmur actually increases. Then most likely you are dealing with regular valvular problem. So if you check for the intensity of the murmur and it's reducing, this is like venous return is increasing, intensity is reducing, going in opposite direction, you'll be thinking towards either MVP. MVP is mitral valve prolapse, ACM is hypertrophic cardiomyopathy. You ask the patient to stand, just apply the principle. You ask the patient to stand, so the venous return should drop. If the venous return is dropping, then for the regular valve problems, you will expect the murmur intensity to also drop. But when you check for the murmur, you realize that the intensity of the murmur in that one is high. Can you see opposite? The arrows are going in opposite direction. You'll be thinking more towards MVP, ACM here. All right. Hand grip. So when you are now doing hand gripping, so this is quite different. For the hand grip, you are clenching. They will mention it in the exam. Hand grip. The patient, when the patient, like you hear a murmur. You hear a murmur. Please, I want you to pay attention to what I want to say here. You are hearing a murmur. The question will now say, the examiner has the patient to do maybe hand gripping or something like that. It's like you are more or less like squeezing the vessels. So when you are squeezing the vessels, you are increasing the systemic vascular resistance. So when you increase systemic vascular resistance, in a way, you are not favoring the outflow of blood from the heart. Please, this is completely different for the systemic vascular resistance compared to the venous return. You are not favoring the outflow of blood from the heart. What it means is that Instead of, because the resistance against which the heart is pumping the blood is now high. So if the heart is supposed to pump out 100 mils per beat, the thing will now reduce to maybe something like 50 mils per beat. Can you see? 50 mils per beat. All right. So when you are having 50 mils per beat going out compared to 100 mils per beat going out, you will have a lot of blood being left behind. So when you have a lot of blood being left behind, the heart, left ventricle will appear distended. So the left ventricle will now appear distended like this. When it's distended, whichever obstruction that is initially blocking the movement of blood out of the heart will be shifted away, because the heart is now distended, because most of the blood is not going out. And with that, the intensity of murmur will reduce in HCM and MVP. So think about it. When the systemic vascular resistance is high, MVP, HCM will drop in intensity. The murmur in them will drop in intensity. When the systemic vascular resistance is low, the the murmur you hear in MVP and HCM will now rise. Because when the systemic vascular resistance is now low, it shows that most of the blood will now leave the heart. So if most of the blood is leaving the heart, this is how the obstruction will now look magnified, because the heart left ventricle will now look smaller. So because most of the blood is actually leaving the heart. So because this area narrowing is now, this narrowing you see here is now becoming more prominent, then you will be hearing the murmur more loudly. Think about it. Systemic vascular resistance, they love it a lot. Systemic vascular resistance, if it's low, so when the left ventricle beats, most of the blood will leave, and that will make the left ventricle to now look a bit small like this. Can you see? It's now smaller. Then this obstruction will now become more prominent. Then because it's becoming more prominent, this place is looking more narrowed, then the murmur intensity, the loudness will increase. Can you see? The loudness, that's another name for the murmur intensity. Loudness will now increase. Can you see? So that's that. All right. So you check for systemic vascular resistance. Now, the last thing I'm going to say here is about Valsalva maneuver. In the exam you want to write, they will mention Valsalva maneuver for you. And don't be carried away by the way we are looking at it and be like, oh, it's easy, oh, it's this, it's that. Because in the next few weeks, you might not be able to remember most of what we are still talking about unless you are intentional about it very well. So they will mention Valsalva maneuver in the exam. So the Valsalva maneuver, there are two phases of them that out of the entire phases that they will mention, that they will link the question to: the release phase and the strain phase. The release phase and the strain phase. The release phase and the strain phase. Can you see? Strain phase, release phase. So for the release phase, I will represent it with letter R. For the strain phase, I will represent it with letter S. Valsalva maneuver. So for the release phase, what I'm going to see is increase. I'm going to see increase in systemic vascular resistance. In systemic vascular resistance. While for the strain phase, I'm going to see reduction in the systemic vascular resistance. Let's see, what are you trying to? So look at what I put here. RIS, SRS. What is the mistake you can make in the exam for you to flip them, right? So let me assume that you are going to make this mistake now. You now write something like release phase is going to reduce systemic vascular resistance, while the strain phase is going to increase systemic vascular resistance. As a rule from me, no two similar letters must follow themselves. Once you can remember, no two similar letters must follow themselves, you will always be correct in your analysis. So you can't have RR So you can say release phase will reduce systemic vascular resistance, while the strain phase will increase. That would be wrong. So you would rather, because you are seeing R here, you would rather have release increasing systemic vascular resistance, while the strain phase reducing systemic vascular resistance. Are you getting it, everyone? Did you get
Yes,
what
sir.
I just
Yes,
explained now?
I did.
All right, good one. So when you read that question and you see them mentioning release phase, strain phase, release phase, strain phase, you have an idea of the way to look at it. So that's how you are going to be looking at it. And that will really go a very, very long way for you. So the question on the strain phase, release phase, and the likes, and the systemic vascular resistance, you can now link it to MVP, ACM, because when the systemic vascular resistance is high, most of the blood will not be able to go out. Left ventricle will become distended, obstruction will be shifted away. Do you get it? Then the murmur is now going to reduce in intensity. Do you get it? But when the systemic vascular resistance is reduced, more blood will be leaving the left ventricle. So the left ventricle will look smaller in volume. The obstruction will now become more magnified. Then intensity of the murmur will increase. So you can easily link this to the other regular murmur. So that's about this. Now, the next important point here on this table is about inspiration. When you must, as a rule, you must never forget, when I inspire here, where is the blood going to? More blood will flow towards the heart. But as someone that is about to write step 2, you don't just say heart. You mention the part of the heart. So when you inspire here, the whole goal is to oxygenate that blood. It shows more blood will flow towards the right part of the heart, not the left part of the heart. Because the whole essence of the left part of the heart is to pump blood towards the entire part of the body. So during inspiration, left heart needs to chill. Left heart needs to chill. Let right heart enjoy. Because during that time, that is when you are favoring more blood towards the right heart for oxygenation at the lung. So what it means is that with respect to the regular murmur, during inspiration, you are going to have increase in blood flow towards the right part of the heart. And that will, if at all there is any murmur on the right part of the heart, it will now be more loud. If there is any murmur at the left part of the heart during inspiration, because the flow towards the left part of the heart during inspiration has reduced, that murmur will also reduce in intensity. Shit. How will I be able to put this together? Relax. You are Dr. Shawama. You are seeing this patient. Maybe the hospitalist, whosoever that you are doing the round with, just listen to the murmur and ask the patient, breathe in, breathe out, breathe in, breathe out. You will now look at where the doctor is putting the stethoscope. You check where the doctor is putting the stethoscope, and that region correlates to the right part of the heart. Breathe in, breathe out, breathe in, breathe out. You say, you check. This murmur is loud here. You now check, where are you putting? Is this related to the valves on the right or the valve on the left? Where you are putting the stethoscope is there, that hospitalist is putting the stethoscope is related to the right part of the heart. You now say, when I ask the patient to breathe in, the murmur becomes louder. It shows we are dealing with the regular valve abnormality. More flow towards the right part. Can you see? And the murmur is becoming louder. So you now check, is it pulmonic area? If it's pulmonic area, you'll be thinking towards pulmonic valve abnormality. If it's tricuspid area, you'll be thinking towards tricuspid valve abnormality. Breathe in, breathe out. But where the hospitalist put the cursor is on the aortic region. Breathe in. When the hospitalist now puts the cursor there, during the inspiration, the murmur now becomes quieter. The murmur becomes quieter. Then most likely you are dealing with regular valve abnormality of the aortic valve. Abnormality of the aortic valve during inspiration. Because during that inspiration, you don't have enough blood going to the left part of the heart. So what the hospitalist will now focus on is during expiration. So during expiration, left part of the heart now wants to push out more blood. So more blood will flow towards the left part of the heart. That's what it means. So in our heart, during expiration, what is happening? Oh yeah, breathe out, breathe out. The hospitalist now say, during expiration, the murmur becomes louder. Yeah, you now check where the hospitalist is putting the should I say cursor, the stethoscope? He's putting the stethoscope. You now say, it's at the aortic region during expiration, which is related to the left part of the heart. So because it's related to the left part of the heart during expiration and it's louder during that time, because during expiration, more blood will flow through the left part of the heart, and the murmur is louder during that period, then you are dealing with regular valve abnormality of that area. So when you are reading your question and they are mentioning inspiration and expiration, it's not a joke. It's actually for thorough analysis, and say that, okay, if this murmur is happening like this, is occurring like this, then this is most likely the diagnosis. I brought out this thing, I call it rings, legs. Right-sided murmur will increase in intensity during inspiration. Left-sided murmur will increase in intensity during expiration. Inspiration and expiration is not a joke when you are reading your question. How many people have gotten my explanation? Do you get it now? Good one. All right. So that's how we look at it. All right. Now, how are you going to look at this area? I put an arrow here. Let's look at the other murmur. How are you going to look at this area? This is actually an image from step 1. So how do you look at it when you are reading your question and the likes? So you call it APTM, APT-M, APTM, APT-M. In your exam, the one you want to write, so they will give you the diagram and you will be moving the stethoscope around on the screen and you'll be checking for what is loud. I want you to have a way of looking at it so that when you sit down with medical students and you are doing your analysis will really make a lot of sense. When you are teaching, when you are analyzing the way to look at it, it will make a lot of sense. So this aortic region, look at the pulmonic region, this is the tricuspid region, this is the mitral valve region, or the apex of the heart. Okay, we start from the aortic region. The question will say, the murmur radiate to the neck. The murmur radiate to the neck. The murmur radiate to the neck. When you are seeing a murmur radiating to the neck, most likely that murmur is coming from aortic region. And that will really, really help you a lot in your analysis. So most likely that murmur is coming from the aortic region. Can you see? Radiate to, and see where you are going to pick it from. So this is where you pick it from, the right side of the sternal border, right sternal border, right upper sternal border. That's what I wanted to say. Can you see? Aortic stenosis. There is also one murmur. Okay, I will mention that later, not now. So just don't forget this, aortic. Can you see where it's radiating to? So they will always put it in the question. It's radiating to the neck, it's radiating to the neck, just say aortic murmur. So aortic stenosis. Aortic stenosis, I say, I never mentioned aortic regurgitation. Let's come to the P here. For the pulmonic region and the tricuspid region, there is a term we are going to call this. We call it the left sternal border murmur. So what it means is that when you get into the exam, they will mention it in the question, left sternal border. So if the question says they are picking a murmur at the left sternal border, it could be the upper, it could be the lower. If it's the upper, pulmonic. If it's the lower, tricuspid. You can also have them just mention left sternal border, which is just the region between the two. Do you get it? Left upper sternal border, pulmonic. Left lower sternal border, tricuspid. All right. So for the pulmonic, it's also going to be pulmonic stenosis. Can you see? Pulmonic, that's what you are thinking about. So if they put their cursor here now, during which period do you think the murmur here for this pulmonic region will be loudest or louder?
Inspiration.
During inspiration. During inspiration. Good one. The same thing for the tricuspid is also going to be louder during inspiration. Good one. So that's how you look at it. We just mentioned a sternal border and the likes. So the kind of murmur they pick, I think there is a time I will be mentioning it later. All right. Now, another thing about this left sternal border that you must note is about ASD and FSD murmur. So where do you pick ASD murmur? You pick it at the left upper sternal border. Where do you pick FSD murmur? You pick it at the left lower sternal border. Now get the gist. Now, give you a question. They say they pick a murmur at the left lower sternal border. I already have two differential in my head. What is the first one? Am I dealing with tricuspid problem or I'm dealing with FSD? That's all. That's all. That's all. Whether I'm dealing with tricuspid regurg or I'm dealing with tricuspid stenosis. Can you see? Tricuspid valve problem, lower. The second problem is FSD. That is why when I am reading a question now, the question is 10 lines. And it's a cardiology question. I will just flow to the murmur. They now say there is holosystolic murmur picked at the left lower sternal border. I just flip through all the options, and the next thing is, what is my answer here? And I say, okay, most likely I'm dealing with FSD here. Most likely, I am dealing with FSD. Okay, what else could it be?
Tricuspid regurg.
It could also be tricuspid regurg, but you check through the options, I can't see any tricuspid regurgitation. Why are we mentioning tricuspid regurg? I will explain it. Okay, let me quickly explain that now. So, there is a term called holosystolic murmur. Holo, that's the term. Holo, throughout that systole, you will be hearing the murmur. So, what does that mean? Anytime the heart is in systole, is beating, poof, poof, you focus on the right part of the heart. During that time, where is the blood? That blood is supposed to go to the pulmonic region. Is this blood having the tendency of going any other place? Yes. Where? They say the right atrium. What can make the blood to go to the right atrium? If there is tricuspid regurgitation. That kind of murmur that will be produced when the blood is going elsewhere during that systole is holosystolic murmur. So it shows that tricuspid regurg will generate holosystolic murmur. Now, come to the left part of the heart. If the left part of the heart is beating, the blood is supposed to go to the aortic region. The question now says that they are hearing holosystolic murmur during that time. What it means is that the blood is going elsewhere apart from that normal place. Where can the blood go to? The blood can go to the left atrium. By what condition? Mitral regurgitation. If we have FSD, the blood will also be flowing from left ventricle to the right ventricle during that time of contraction. It shows that those two places, those two conditions will generate holosystolic murmur. So you are reading your question, you now see the word holosystolic murmur. I have 3 wonderful differentials. Number 1, FSD. Number 2, tricuspid. Number 3, mitral valve, regurg. Number 1, FSD. Number 2, tricuspid regurg. Number 3, mitral regurg. But the question says holosystolic murmur, loudest at the apex. That will be mitral regurgitation. Holosystolic murmur, loudest at the left lower border. It's either I'm dealing with tricuspid regurg, or I'm dealing with what? FSD. That's how you look at it.
VSD.
So the question will be the one to now be guiding you. This is what you do. This is how you do it, and the likes. So that's about this. That's about this area. I'm coming now. That's about the tricuspid area. All right. About the holosystolic and the like. What about the mitral region? The mitral region. The question will say the murmur radiate towards the axilla. So it must be put. They must mention it. The murmur is radiating towards the axilla. So if it's going towards the axilla, once they say the murmur is radiating towards the axilla and it's loudest at the apex, you are thinking towards mitral. So if it's mitral regurg, it's going to be holosystolic murmur. Do you get it? If it's mitral stenosis, it's not going to be holosystolic. Never forget that one. So that is how you are going to be differentiating them. Okay, now, Festus. You only mentioned aortic stenosis, pulmonic stenosis. You never mentioned anything about aortic regurg. You never mentioned anything about pulmonic regurg. Yes, thank you so much. I never mentioned them. There is something about those two bastards. You see this region between P and T. That is where you pick upper regurgitation. What are these upper regurgitation? Pulmonic and aortic. Pulmonic regurg, aortic. So you will see them between here. So how are they going to mention it? They mention they are picking a murmur at the left sternal border. They will not say left upper. They will not say left lower. They will just say left sternal border. They are not saying upper or lower. So you don't even know which one to go to. So one of the things you are going to be thinking about is upper regurgitation. Is it pulmonic regurg or aortic regurg? And one more thing, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. So when you see this now, you have a pictorial way of looking at it. Aortic going to the neck, mitral going to the axilla. Can you see? And you look at the sternal borders. Very good. There is a concept called flow murmur. There is a concept called flow murmur. Mm-hmm. Flow murmur is a benign murmur. Flow murmur is a benign murmur. And the thing about it is that it changes. We change in position. That's all that we give it out. It changes with change in position. It changes with change in position. Any question you read, they say they are picking a murmur. But when they turn the neck of the patient, the murmur disappears. When the patient looks up, the murmur disappears. When the patient turn the head down or start looking down, the murmur disappears. When the patient just turns to check on the nurse, the murmur disappears. When the patient rises from bed, once you start picking a murmur that changes with position, you will be thinking towards flow murmur. It is benign. It is not something you will be shouting, go and do echo for. That's what they want to test. So there is a word you must now put at the back of your mind. That word is positioning. When you are reading your question, The murmur you are giving me, is it changing with position? They say it's changing with position. And I say, what is your best next step? Your best next step is reassurance. There is nothing to worry about. It's just a flow murmur. The way the blood is flowing through the vessels. Flow murmur. Do not worry. That's all they want to see. Reassurance. In fact, they will write all manner of jargons. They now say the murmur is changing with the change in the neck position. That is a flow murmur. So you don't do anything before you start saying that, what's the benefit in saying ECG? ECG for what? Nothing. All right. So you can see the flow murmur here. The pulmonic region. You can see the flow murmur here. Aortic region. So anywhere they put it, they can tell you that the flow murmur is also radiating to the neck. It's radiating to the neck. So don't be cajoled. Look out for that change in positioning. So,
Dr. Professor, before we move, where's the best place to hear ASD?
ASD, you hear it here, pulmonic region.
Okay.
So this will be ASD murmur. Why this one will be phi SD murmur? Okay, AV. All right. So, do you get it now? That's
yes,
good. So now look at the holosystolic murmur. I've already mentioned it. Then you will also be picking it at the phi SD. Can you see holosystolic murmur? So I'm not going to go into them again. Aortic stenosis, you already know it will radiate to the neck, to the carotid region. Mitral valve prolapse. So you will also be picking this at the apex, just something related to mitral anyways. So aortic regurgitation. Something we give out aortic regurgitation in the exam. Wide what? Pulse pressure. Wide. So just give you the blood pressure 170/60, just as I've written something here. If you look at the systolic and diastolic, the gap is very wide. So in this regard, you say the pulse pressure is wide. Pulse pressure is just the systolic blood pressure minus diastolic. Is very wide. So because it's very wide, so you start thinking towards something like aortic regurg. All right, so don't forget that blood pressure will give it out. So this is mitral stenosis. There is a sound you will hear here. You call it snap. You call it snap. Steno snap. Stenosis will give you a snap sound, while the mitral valve prolapse will give you a click sound. So now, how do you look at these guys? You are going to look at them like this. They will mention the first R sound, number 1, second R sound, number 2, first R sound, number 1, second R sound, number 2. But let me clean the last one. First R sound, first, second, one. First, second, first. First, second, first. First, second, first. I want to do the analysis for mitral valve prolapse and mitral stenosis. What will be my reference R sound? Your reference R sound will be the second. Most of the time, when you want to do analysis in the exam for one R sound, you actually use the second. All right. How will I look at it? If I am hearing a sound, the question says, there is a sound. Okay, before I go there, before I nail that one for you, you have heard about systole. You have heard about diastole. So when I hear the first sound, boo, second, boo, first, boo. So I know that there is something called systole. And I know there is something called diastole. Systole will occur between 1 and 2. Diastole will occur between 2 and 1. If you look at it, I only wrote down 1, 2, 1. Then I arranged the letter CD. Systole, diastole. Okay. Look at the word mitral valve prolapse. Pro. What does pro means? Pro. Pro. What does the word pro mean? Pro means before, right?
Yeah.
Good. So what it means here is that you are going to hear the click sound in the mitral valve prolapse here. This is where you are going to hear it. While you are going to hear the snap sound in the mitral stenosis, you will hear it here. Okay, now let us look at the way they will now write it. So for the mitral valve prolapse, they are going to call it a mid-systolic click. Pro means before 2. You can look at it like that if you wish. Pro. Mid-systolic click. So how do you think they will call this one for the stenosis? How do you want to call that one for the stenosis?
Mid-diastolic.
Diastolic.
Mid-diastolic. So let us check if you are correct. Mid to late low P diastolic murmur. Does that make sense to you? So immediately you are reading a question, you've forgotten, where am I going to hear click? Where am I going to hear snap? You now check them, you now start seeing mid-systolic. You just hear, this is click now. Mid-systolic, this is mitral valve prolapse. You are seeing mid-diastolic. That's going to be for the stenosis, mitral valve. Do you all understand what I've said so far, everyone? Oh my God. Have you understood what I've said so far?
Yes.
Good. And you can apply this to some questions, right? We hope so. Okay, all right. So, now look at the patent ductus arteriosus. What kind of murmur do you hear here? You hear what we call continuous murmur, machine-like murmur, continuous machine-like murmur. Where is it going to radiate to? It's loudest at the S2 and is best heard at the left infraclavicular region. So continuous murmur. Now, there is another condition that will look like this. You call it venous hum. It's also continuous, and this one radiates towards the neck. It's due to turbulent flow of blood in the internal jugular vein, and it changes with neck flexion. So what kind of murmur will you call this venous hum now? Flow what?
Flow murmur.
Flow murmur. Good one.
Flow murmur.
It's benign. So you don't bother yourself. You don't need to be shouting, I want to do this or do that. So why am I mentioning this? Because it's also continuous. So that you won't just see continuous and you start shouting, PDA, PDA, PDA. That will be wrong. It's not going to just be PDA. So you check, is it changing with position? So positioning is a key fact you must look out for in your exam. Now look at what I just explained to you. Put here, pro click, you can see before the S2. Steno snap is after the S2. That's just what you need there. And look at the flow murmur. It's usually a soft murmur that is position dependent. That's the word. Very common and does not imply cardiac disease. So what you do is that you reassure them. It's common in children and young adults. No trills. It's actually usually systolic. It's systolic. All right. What about the gallops? When you get into your exam, you see S3 has sound in any question. So you must be thinking towards fluid overload, congestive heart failure, congestive heart failure, congestive heart failure, and the likes. Pregnancy, something like that. So S4, you must be thinking towards something like the heart becoming thickened. So the heart cannot relax the way it should. Aortic stenosis, diastolic dysfunction, hypertension. So just like the ventricles, they are now very thick. So S4. So in the exam, they will mention S3. Be thinking towards something like congestive heart failure. For the S4, be thinking towards hypertrophic heart problem. This is the Rainslex I've told you about. All right. This is the edema. You are seeing pulmonary edema. It shows that the blood cannot leave the lung towards the left heart. Maybe the left heart has failed. So blood is now backing up into the lung, pulmonary edema. So it's a sign of left heart failure. Peripheral edema is a sign of right heart failure. So when you see peripheral edema, don't forget how you do your hepatojugular reflux. So, and S3. S3 will show you that there is right heart failure, or there is congestive heart failure rather. Hepatojugular reflux, when you do it, and you realize that when you put a pressure on the liver, you are seeing the reflux. You are seeing the jugular venous distension. Do you get it? What it means is that the edema of that patient is coming from the heart problem. So when you put pressure on the liver and you are not seeing any jugular venous distension, most likely the problem is coming from hepatic condition. In infective endocarditis, you are going to see splinter hemorrhages, Osler nose, Janeway, lesions, and we'll look at all these things later and the kind of questions they will ask in them. What about the peripheral pulses? These are the peripheral pulses. It can be increased in aortic rigor. You call it bounding pulse. They will mention it. When they say that it's greater in the upper limb compared to the lower limb, so maybe you are dealing with coarctation of the aorta. It can be decreased in peripheral arterial disease. It can be collapsing also in aortic incompetence or regurgitation. You can also have a condition called pulsus paradosus. Pulsus paradosus. So what is pulsus paradosus? So let me try to make an illustration for you. Pulsus. So let's look at this picture. So look at this picture. I want to use this picture to explain this pulsus paradosus for you. So they call it pulsus paradosus, even though it's a pulse they are putting there, but it's actually all about blood pressure. So what is going on? During inspiration, more blood is supposed to go towards the right part of the heart, while less blood is supposed to go towards the left part of the heart. And don't forget that the blood pressure that you are measuring is actually linked to the left part of the heart. So what that means is that during inspiration, when you try to take your blood pressure, during inspiration, the blood pressure will be low. The systolic blood pressure will be low. It will be reduced. Because blood is not really flowing towards the left part of the heart as such during inspiration. So more blood really stay within the right part of the heart for oxygenation. So that blood pressure, systolic blood pressure will drop. Now, pulsus paradosus is all about that drop. Is that drop now more than 10 millimeter of mercury or not? So if you check that systolic blood pressure and the question says it is dropping by more than 10 millimeter of mercury, your answer is pulsus paradosus. If there is any drop, it must not go beyond 10 millimeter of mercury. So when they now give you this graph, what they want you to check is the drop. During inspiration, 124, 124. And that's during expiration rather. During inspiration, you now get 110. You now have 124 minus 110. That is 14. Because the difference between here and here is already more than 10. You see, this patient has pulsus paradosus. So you now come back to the question and now check what are the likely causes. We usually put them under the canopy of COAT. C-O-A-T. C is cardiac tamponade. O is obstructive lung disease. A is asthma. T is tension pneumothorax. So when you see pulsus paradosus, your answer will be any of these. But in case they list all of them, you are just going to check the question and check for the premise that is laid there. All right. So that's just by the way, that's how you look at the pulsus paradosus. Do you all get it now? Do you get that?
Yes.
Okay, lovely. All right. What about the pulsus alternans? So you just be seeing alternative weak and strong pulse. 6. You see this in cardiomyopathy. Pulsus perfus et tardus is just talking about weak and delayed pulse. Weak. Jerky pulse, you see it in Ocum, hypertrophic obstructive cardiomyopathy. Pulsus Bis variants like bifid pulse, you see it in aortic rigor and the likes. All right, so the last thing I'm going to mention here is what we call the atrial myxoma. But I think before I come here, let me quickly show you one or two questions on this cardiac exam. So let's see how you look at those questions. How many questions do we have here? So we have quite a number of questions. So let me just solve one with us, then you have an idea of how you look at it. I'll solve two, actually. The first two. A 6-year-old girl is brought to you for a well child examination. She has no history of serious illness. Temperature is fine. Pulse is okay. Blood pressure is also looking good. Examination is showing grade 2 continuous low pitch murmur over the left upper sternal border that radiate towards the neck. So, first of all, what kind of murmur is this? Where are they picking the murmur? Which area? A area, P area, T area, M area? Which of them?
P area.
That's the P area.
P area. Okay. All right. Now see, the murmur disappears when she flexes her neck. So what kind of murmur is this?
Flow murmur.
So flow murmur, benign murmur, any other name you want to call it. The remainder of the examination shows no abnormality. Which of the following is the most likely diagnosis? So you'll be thinking towards something like benign murmur, flow murmur, Faynor's hum. Does that make sense to you? So you can see that's how you will be reading the question. You don't need to do too much analysis. Now, I want you to, where did I tell you the flow murmur usually occur? During which phase? Systole, diastole, which of them?
Systole.
Systole. So I want you to look at this question and pick your answer for me, please. A 4-year-old girl is brought to you for a well child examination. She has been healthy apart from an episode of bronchiolitis as an infant. Her 6-year-old sister recently underwent surgery for ventricular septal defect closure. That's the sister, not the patient. The patient is at the 68th percentile for height and weight. Her mother is concerned about the possibility of the patient having a cardiovascular abnormality. Which of the following is most likely to indicate a benign heart murmur? So which of them do you want to pick? Benign heart murmur. Do you think benign heart murmur will be holosystolic?
I'm looking at D.
D. So continuous. Do you think it's going to be holosystolic?
No.
Do you think it's going to be machine-like?
No.
Yeah. So do you think it's going to be... So you can check it for the rest anyway. All right. So you are going for what? For
Option
D, right? Good. So that really makes sense. So, so grade 2 continuous murmur hard at the right supraclavicular. That's a very good example of benign murmur. So the thing is that it will look like you are dealing with all this PD here of a thing. So that's just by the way. Permit me to just continue so I won't give you a break. All right. So this is atrial myxoma. Atrial myxoma is a benign tumor of the heart. Where do you see it? You usually see it in the left atrium. So what they will do in the exam is that they will give you the picture, the echo. So when they show you the echo, you will now see one small mass that is attached to the interatrial septum. Can you see? Within the left atrium. You will just see something there. So what happens there is that tumor can easily roll in a way and obstruct the opening. It's just going to just block it. So it can easily create a blockage, which means that the blood in the left atrium that should empty into the left ventricle will not, because there is an obstruction at the entrance or the the connection. So that obstruction will shall block the blood from going from the left atrium to the left ventricle. So that means that during that time that the tumor is rolling there, enough blood will not be pumped out of the body, and the patient will experience what we call syncopa, something that looks like a syncopa attack. Can you see? Something that looks like a syncopa attack. So the patient will just be losing consciousness with some change in positioning, and that will give it out. That's number one. Number two is that this is a tumor. It's a tumor. It's a benign tumor. So the patient can have some what we call non-specific constitutional symptoms like fever, weight loss. This fever, weight loss, they will ask you in the exam in step 1. I'm saying this for the purpose of step 3. What is responsible for it is interleukin 6, tumor necrotic factor alpha, and the likes. They will just ask you for the interleukin that's responsible for that. All right, so that's for the constitutional symptom, fever, weight loss, and the likes. So the next thing you can see is that the tumor can be breaking out small from there. And when it breaks out small, where will it go? It will actually go to, the other part of the body. Don't forget that it's coming from the left atrium to the left ventricle, from there to the whole part of the body. So you can see systemic embolization. The patient can also have arrhythmia, because if the blood in the left atrium is not completely emptied, the left atrium will dilate, and that will make the patient to develop left atrial enlargement, which can predispose to arrhythmia, like atrial fibrillation. So arrhythmia can occur, like atrial fibrillation can occur when there is dilation of chambers. Anytime there is dilation of chambers, arrhythmia can develop. So never forget that. Now, there is something they will put in question that will give it out. What is that thing? Tumor plop sound. So they just say when you auscultate the patient, tumor plop, a plop sound is heard. You see the way they put it? They put it in quotes. That's how they are also going to put it. That shows that this name is peculiar. They will also put it like that in the exam. You will just say that this is atrial myxoma. What's the best next step when you see this? They say this patient is having intermittent syncopa attack, intermittent this, and the patient is having fever, is having this, is having that. And that's what's the best next step. You go for echo. That's the answer, echo. So now you've done echo. You see this is atrial myxoma. What's the next thing? You go and do tumor resection. So it's going to be open heart surgery. So go and do it. And possibly they have some other alternative way of treating it. So just know the answer is tumor resection. Okay. Now, you see, your numbers reduce significantly to, is it a significant level or insignificant level? People run away. Now, let me encourage you people. It's just an encouragement for you with respect to the recent administration. You see, it will come and go. I'm talking about all manner of policies and the likes. So if you, because of whatsoever that is going on now, relent in your preparation, I think you will be making a very big mistake. So you still continue, you continue writing your exam. Like, just keep writing. In fact, it's like you have enough time. Keep writing. And the thing about USMLE is that it doesn't only prepare you for USMLE, it also prepares you for good medical practice. So if I ask you now, have you picked one or two things from whatsoever we have discussed so far today? Do you think whatsoever we've discussed is quite helpful even in your practice? So, okay. All right. So that's actually how the exam is. So it doesn't only prepare you to practice in US, it's preparing you to practice anywhere. And that's that. All right. So be encouraged. Okay. All right. Now you come down to the arrhythmia. How do you look at arrhythmia in the exam, or generally? I want to show you the way to look at arrhythmia. Simple way. You can go and complicate the matter for yourself later. But how will I be looking at arrhythmia? First of all, There is what we call the normal heart rate, 60 to 100. So if I am getting anything lower than 60, I call that bradycardia. If I'm getting anything more than 100, I call that tachycardia. All right. So if I am seeing the rhythm is quite irregular and all manner of stuffs, and the heart rate is less than 60, I can be thinking towards something like bradyarrhythmia. If it's more than 100, like it doesn't really, like I can be thinking towards something like tachyarrhythmia. Now let's start with bradyarrhythmia, and I will be very specific with us here how the question will come. So we have what we call the sinus bradycardia. What it means is that you will be given the question, and you will see the QRS complex being preceded by P wave. But when you look for the heart rate, you count it, you'll be getting something less than 60. That is brady. So when you see this, the first thing is what could have been the cause. What could have been the cause? We mentioned them early in our study today. Maybe the patient is an athlete. Maybe the patient is doing physical fitness. You are dealing with syndrome. You are dealing with maybe AV nodal blocking agent, like the patient is on beta blocker or non-dihydropyridine calcium channel blocker. These are the causes. Do you get it? It's a normal response to cardiovascular conditioning. So never forget that. So now, what do I do when I see a patient with sinus bradycardia question? What you are going to always be checking for is this patient symptomatic? So if the question says the patient is asymptomatic, your answer will be reassurance. If the question says the patient is symptomatic, the first line, the best next step will be to give the patient atropine. Can you see? So your duty in the exam is to check for symptom. You are seeing this patient, the question will come and be like 40-year-old man coming to you, this one, that one, heart rate is 52. The nurse standing with you is concerned, the patient is raising eyebrow. Doctor, what will you do here? A, reassure. B, give the patient atropine. C, D, that. So they shall list all manner of stuff. So what you will do is to now check, are you having any symptoms? The patient say no symptoms, no fever, nothing, no headache, no dizziness, no. They shall list all manner of jargons, nothing. So what do you now want to do? What you will do is reassure. Oh, the patient has been having lightheadedness, feeling dizzy, this one, that one. What's the best next step? The answer is atropine. So in the exam, the most tested treatment is either reassurance or you give the patient atropine. Before you start cramming these jargons, transcutaneous spacing, dopamine, this one, that one, temporary transvenous spacing, and the likes. Before you go for that, check the question very well. Hope I'm not about to pick nonsense. Do you get it? So I put an arrow here because this is what everyone really wants you to pick and note for the exam. When you want to reassure and when you want the patient to collect atropine. The last question I will bring out for you is that what is the definitive treatment? Definitive treatment is different from best next step. Definitive treatment to reduce recurrence of whatsoever the patient is having is going to be pacemaker implantation. Definitive treatment. So look at this definitive treatment. Look at the best next step. Look at when you want to reassure the patient. So what you are checking for is, do you have symptoms? Don't you have symptoms? So I want you to look at this question. 59-year-old woman is brought to you after collapsing at home. the woman and all her children, the husband, everyone at your office shouting, "Doctor, help us. Mama must not go like this." She has been sitting on her couch reading when she started feeling lightheaded and lost consciousness. According to her husband, she was unconscious for approximately 30 seconds. Since regaining consciousness, she has continued to be lightheaded and dizzy. She has not had palpitation. Her only medication is simvastatin for hyperlipidemia. Pulse is 37. Then you wait. You say, "What did you say pulse is?" "Let me count it by myself." You count it again. You bring out you count it again. You say 37. Respiration is good. Blood pressure is 92/55. You now say, "Let's do ECG. How come your pulse is this low?" The reason why you are shouting ECG is this. You look at the blood pressure. Even, is mama having, you are not even asking, has she been vomiting? Has she been having diarrhea? How come your blood pressure is also a bit low? You are not even saying that. Because if the problem is from blood pressure, you expect the pulse to actually go up. But the pulse here is down, which means it's even the pulse that is making the blood pressure to be low. Can you see your thinking? You could have been like, the vital signs is not okay. It's this. What is the blood pressure? It's a bit low. Then the question is, what is the pulse? The pulse is also low. It's not possible for pulse to be low when the blood pressure is low. There must be a response. It's not common. I think that's what I should say. It's not common. Something else is going on. It is most likely the pulse that is low that is making the blood pressure to be low here. Oh yeah, what could have made the pulse to be low? Let's quickly do ECG. Then they now give you the ECG. You check the ECG. Let me see what the ECG is like. Then they give you this ECG. You now remember, I want to look for the total number of the big boxes. 1, 2, 3, 4, 5, 6, 7, 8. So you can see that it's very, very wide. Is it even sinus? You can see Q wave. You can see P wave preceding QRS complex, P wave, QRS, P wave. So this is sinus reading. You now check again. So this patient is having sinus bradycardia. Which of the following is the most appropriate next step? The question is she symptomatic? So if the question says the patient is symptomatic or asymptomatic, your answer will be just reassure. If the question says the patient is symptomatic, the best next step will be to give the patient atropine. So you now quickly flip through all the options and pick atropine. So your answer is C. What about all the other options? Can't I use them? You can use them. So your exam is not about how much you know. It's all about how much orderliness you put into what you know. Can't I use dopamine? You can use dopamine. But dopamine is not what you give to this patient now. Can't I use epinephrine? You can use epinephrine, but epinephrine is not what you give to this patient now. Can't I use pacemaker? You can, but it's not what this patient needs now. See all your answers. They are all there. But what do they want you to bring is the best next step, because you are going to be the first responder to that patient. So whether the patient will live or die lies on your shoulder. So it's not about your stuff. It's about your order. It's not about how much you know. It's about how can you narrow what you know towards the survival of that patient. So if you will cram anything, it's all about, if that patient is symptomatic, I will treat. If that patient is asymptomatic, I will allow home or monitor the patient. You are the one on call. They rush the patient there. The patient is fond of the habit of taking his blood pressure by himself. He is aware that the normal blood pressure should be 60 to 80. it's 200. The patient does his own and is seeing something like 58. The patient is now coming and saying my pulse is low. So when you are the one on call, you now see this patient. Now say, what do you want to look for? First of all, are you feeling lightheaded? Are you feeling dizzy? Have you lost consciousness? You just be asking all those symptoms. The patient is saying no, but my pulse is low. You now say, do not worry. That's your answer. So you just reassure that sometimes you can have that. Maybe you've been exercising a lot, you've been doing this, you've been doing that, and all manner of stuff. But if the patient is symptomatic, then you must treat. That's all. All right. So that's about the sinus bradycardia. Come down to the AV block, heart block. So now, how do you look at the heart block in the exam? I want you to really pay attention to what I want to show you. Yeah. So with respect to the heart block, it looks like what we just did not quite long. All right. So you check it, you realize that the PR interval is actually prolonged. But if you come to the sinus bradycardia, it is not about the PR as such alone. It's not about the PR alone. Do you get it? So please watch out for that. So you check here, the PR is prolonged and it is constantly prolonged. It's not progressively getting prolonged. So the PR here is more than 3 to 5 small boxes. Is more than 3 to 5 small boxes. Is more than 3 to 5 small boxes. Is more than 3, and all of them are the same. That is first degree AV block. So what could have caused it? Increase in Fager tone, beta blocker, calcium channel blocker, non-dihydropyridine. What do you want to do? Your answer will still be the same. You check, are you asymptomatic? You say yes, don't do anything, just reassure. Are you symptomatic? Yes, then give atropine. That's all. That's all. If you look at it, it's not something highfalutin. Give atropine. Are you this? Are you not that? So now come down to the second degree AV block. Hey, what did I do? Come down to the second degree AV block. So with respect to the second degree AV block, that is when you check the PR interval and is progressively getting prolonged. Can you see? Is progressively getting prolonged. That's second degree. So there are two types you have here. You have the Mobis type 1 and you have what we call Mobis type 2. All right. So with respect to the Mobis type 1, you can see progressively getting prolonged. Then the next thing is there will be a drop. You won't see QRS complex at all again. That is Mobis type 1. For the Mobis type 2, is not progressively getting prolonged. Then eventually I see a drop. Think about it. Think about it. If it's getting progressively prolonged, then you see a drop. Do you know that in a way you're already programming your mind? Like the husband comes home 5 p.m. today, tomorrow 6 p.m., next tomorrow 7 p.m., next one 8 p.m., next one 9 p.m., next one 10 p.m. Do you know that the day he comes home 12 p.m., will you be bothered?
Not at all.
Not at all. Because you've been coming late, actually. You won't be bothered. You will just sit down and reassure yourself. I know you will come. That's how you used to come. That means in Mobis type 1, you reassure. Unless it is symptomatic. 2. So if the patient is asymptomatic, you see that it's just progressively getting prolonged, then it drops. You can see it again. KRS complex. You don't bother. Just ask, are you having symptoms? No. Reassure. Are you having symptoms? Yes. You treat. Which drug? Atropine again. Now, come to the Mobis type 2. This husband comes home every 4 o'clock. The day now comes. 4, you do not see. 5, 6, 7, 8, you do not see him. By 9 o'clock, I'm very sure you will have been at the police station. Which means everything is okay. PR, okay. Then there is a drop. Why? Sudden drop. You need to treat. This one, there is nothing like whether symptomatic or asymptomatic. You must treat. Can you see? So Mobis type 2, you must treat. Whether symptomatic or asymptomatic. I'm very sure the patient will have been palpitating and be like, where's my husband? Where's my husband? Where's my husband? Or where's my wife? So that's how you look at it. So what they want you to take to the exam is, do you want to treat? Don't you want to treat? Do you want to treat? Don't you want to treat? And check it. Everything is regular until the time you see a drop. All right. So if you come here now, how will you now assess the patient? If the patient is unstable, what you are going to first of all do for the patient is immediate transcutaneous pacing. You see? Immediate transcutaneous pacing. This patient is not stable. This patient is not stable for any procedure to have a pacemaker yet. You first of all do immediate transcutaneous pacing to help the patient out, to remove all those drops. To now prevent the patient from experiencing it later, you must now do this permanent procedure, pacemaker insertion. So the patient will now be on pacemaker. So what does that mean? If this patient, you are seeing this patient, you already know this is Mobis type 2. You now check, is this patient stable or unstable? How do you determine stability of a patient? Is this patient hypotensive? What is the pulse? What is the blood pressure like? What are the symptoms? Maybe the patient is already losing consciousness, having all manner of stuffs. All those ones will make the patient unstable. Put the patient under the category of being unstable. If they are there, you say the patient is unstable, your answer will be immediate transcutaneous pacing. You check all those stuff, they are not there, your answer will be pacemaker. That's all. If this patient has Mobis type 2 and the patient is stable, just go to pacemaker straight. You don't need to stabilize the patient. Let me show you the way the question could come, just for you to have an idea of how this could be. A 72-year-old man presents to the emergency with a recurrent episode of dizziness and near syncope over the past 2 days. And the children are shouting, Baba ti dagba, where did you allocate all your properties? Have you filled your advanced care planning or advanced directive? Everything. We say, yeah, Baba has filled everything. He denies chest pain. Are you having chest pain? No. Palpitation? No. Shortness of breath? No. He has a history of hypertension and coronary artery disease. His medication include metoprolol, aspirin. On examination, his blood pressure is 110/70. Looking okay. You now check the heart rate. It's 40 beats per minute. So this is low. Out of everything you've seen, you are like, is it sinus? Is it? Now check, they say it is irregular. Wow. There is an arrhythmia going on here. Lung auscultation reveals clear breath sounds. ECG shows regular P waves, with some P waves not followed by QRS complex. Can you see? Some P wave not followed, which means QRS complex was not there. There is a drop. So immediately you see this, you say, what am I most likely dealing with? I know this is all about heart block. Which one now? You now check, they say, and a constant PR interval. In Mobis, type 1 AV block, first degree AV block, there is increase in PR interval. Very wide. Can you see? It's wide. In second degree AV block, you start talking about drops. You check here, there are drops here. Immediately I see the drops, I already know this is second degree. Is it now type 1 or type 2? You now check the PR interval. If it is irregular, if the PR interval is irregular, is not constant, you are going to be thinking more towards something like, type 1 and the likes. But in a situation where it is actually constant, you are most likely going to be thinking more towards Mobius type 2. So immediately I see constant PR interval, Mobius type 2. How do I arrive at second degree? Because of the drop. I'm seeing drops here, second degree. I'm seeing drops here, second degree. Is it now Mobius type 1 or Mobius type 2? What is the PR interval like? The PR interval is constant here. Can you see? It's normal. In fact, constant, normal, anyhow you want to look at it. So this is most likely Mobius type 2. And with this, you must treat this patient. You now check, is this patient stable? Is this patient not stable? This patient is not stable. Someone that is having all this dizziness, syncope, keep naming all manner of stuff. This kind of patient, you want to first of all stabilize him. And what do you use to stabilize him? You give the patient transcutaneous pacing, immediate one. So perform immediate transcutaneous pacing. Now let us assume that the patient has been stabilized. They now say, what do you want to do next? That is when you go for pacemaker. Your answer will not be pacemaker. But you don't even have pacemaker here. All right. What about atropine? You don't use atropine here. So just for you to be aware. Look at this second question. A 64-year-old woman is hospitalized following a syncope episode. Her medical history includes diabetes, mellitus, and prior MI. She is not taking any rate-lowering medications. Her ECG reveals more P waves than QRS. How come I have more P waves than QRS with a fixed PR interval? PR interval is not fixed in Mobius. But before I even go, I'm seeing more P waves than QRS. It shows that I'm having some P waves that are not followed by QRS. There is a drop. That will quickly bring me to the second degree. The next thing is it now Mobius type 1 or Mobius type 2? I will check for the PR interval. Is it normal? Is it not normal? Is it regular? Is it not regular? So, because it is normal, I'll be thinking more towards Mobius type 2. All right. Check. Lab shows normal electrolyte, cardiac enzyme within normal. What is the most likely underlying mechanism here? You are thinking towards Mobius type 2, second degree AV block. So, how do I want to know what is going on here? You see, Mobius type 2, second degree AV block, third degree AV block, they all belong to a problem in the Purkinje system. Whereas Mobius type 1, second degree AV block, first degree AV block, they all belong to AV nodal problem. AV nodal problem.
Can you repeat that, Dr.
Yeah.
Fesofi?
First degree AV block, second degree AV block, Mobius type 1, they belong to AV nodal problem. While second degree AV block, Mobius type 2, third degree AV block belong to Purkinje problem. Is Purkinje problem. That's what bundle of is Purkinje problem. That's the word. Is Purkinje problem. So when you pick your first degree AV block, immediately you pick that. Then ask where is the problem. Your answer will be in the AV node. You see second degree AV block, Mobius type 1, your answer will be in the AV node. But you see second degree AV block, Mobius type 2, your answer will be in East Purkinje system. You see third degree AV block, your answer will be in the His-Purkinje system. All right. So that's how you look at that. You see? Can you see? Look at here, PR interval. What is happening in the second degree, Mobis type 1? Can you see it's also becoming progressively increasing? Here, it is prolonged. First, Mobis type 1, second degree, becoming progressively lengthened. Then there is a drop. Do you get me? So you have drop in second degree. So when you get into the exam, what you are looking for is, what am I having here? Do I have drop or don't I have drop? So when you read that question and you see a drop, quickly come to second degree. There is a drop. The next thing is it now Mobis type 1 or Mobis type 2? What you will check for is this PR interval. Is it regular or irregular? If you check the PR interval here, it is irregular. For the Mobis type 2, it is regular. Can you see? It's regular, then there is a sudden drop. In that one, it is irregular and you have a drop. So you are not really bothered here unless the patient is symptomatic. But in a situation where everything was regular until there is a drop, then you need to do something. Okay. Do you all get it, everyone?
Yes.
Or you have all escaped? I will soon leave all of us, but I just want to be sure that you've gotten something. All right. So that's for this one. Let us look at the third degree AV block. Now, how will you be looking at this? What you will check for is RR. So come here. So RR interval here is regular. RR interval here is not regular because there is a drop. RR interval here is also not regular because there is a drop. RR here is not regular. So, but check this one. RR is regular. So when you check the question and you see the RR interval being regular, you have two things in your head. It's either you are dealing with what? First degree or what?
Or third degree.
Or third degree. Once it is not regular, don't think about these two. If it's regular, it's either you are dealing with first degree or third degree. You are now going to go to the P waves. If the question is now saying you are having all manner of P waves, can you see? All manner of jargons P wave that are just coming up, multiple of them, in the presence of this regular, RR, then that is third degree. Because you don't have all these multiple P waves in the first degree. They are not multiple, they are just one. Can you see? P, P, P. But imagine you have like 3 or 4 P's here, 3 or 4 P's here, 3 or 4 P's here, because they are multiple. And you see regular RR, then you'll be thinking towards third degree. So can you see the difference? So you usually say that the atria is contracting on its own. The ventricles are also contracting. The atria are contracting on their own. Ventricles are contracting on their own. So you can see that desynchronization between them. So when you see that, you'll be thinking towards third degree. What's the treatment? Straight up pacemaker. Treatment straight up pacemaker. Okay. All right. So that's just by the way. What about sick sinus syndrome, or you call it tachycardia, bradycardia syndrome? So usually see this in older patients. All right. Usually see this in older patients is as a result of degenerative conditions. So when you check the age of the patient is 80-something, 90-something, and is having bradycardia. One of the things you think about straight up is most likely I'm dealing with sick sinus syndrome. When the sinus is sick, there are degenerative changes going on in the sinoatrial node. Just like you see degenerative changes in other parts of the patient body. You can also see it in SA node. So when you see this, the patient will be having bradycardia and an occasional escape beat. So when you are seeing those occasional junctional escape beats, that will make the patient to have occasional tachycardia. Then the patient will, it's occasional. They can give you ECG that you won't see that junctional escape beat there. So it doesn't. So age of the patient will be a very good clincher. for this one. All right, what is the treatment? Pacemaker. So when they bring the patient, don't go and be saying, are you symptomatic? No. Once you see the age, the next thing is most likely it's a degenerative problem. So we might need to put Baba on a pacemaker. All right, so that's just by the way. That's how you look at that. Let me show you this question. All right. So 71-year-old man comes to the emergency department because of 3-day history of intermittent shortness of breath, palpitation. The episodes are unprovoked and occur randomly. The day before, he felt lightheaded while walking and had to sit down abruptly to avoid passing out. So you shall check everything you are seeing. Let me bring out the ECG. 6 sinus syndrome, ECG 1. So this is what you have. Can you see? You look at the age of the patient, 70 something, and you can see this bradycardia. You see, very wide bradycardia. All right. And when you look here, you can see some escape bits here. You can see them here. Something that look like that. All right. So that's what you can see here. So when you look at the age of the patient, so most likely you are dealing with 6 sinus, which is a degenerative problem in the SA node. Okay. All right. That's why the degeneration of the SA node automaticity. So for now, I think I'm going to stop here. I think you have tried. We are already on page 13. Oh, that's cool. Not bad. Have we learned 1 or 2 things?
Yes.
Yes, sir.
Yes,
So
thank you.
yeah, so yeah, that's a very good one. So go back, pick the rest. We can go beyond this by tomorrow. By tomorrow, I will be meeting with the people that want to do step 1, and we'll be looking at their neuro. If at all you want to join, you can join them too. There is no knowledge lost. You can join them. We'll just joke around all those pages together. And for those that have our subscription, please focus, study. It will look like it's long. Look at what we did. It's like roughly going to 4 hours. But it's not a waste of time because we need to calm down, explain things, solve some questions. We are not even really solving questions here. You now imagine we now pick all those questions and we are now going through them one by one. So all those things actually take time. So sometimes people don't know what they want actually. You pick a stone and you are using a stone to kill many birds. That's better compared to you just when you are now done, you now go and carry question again. So it doesn't really make sense. So when you are looking at 3 hours video, 4 hours video, look at what is being done in those videos. Then I talk very slowly so that everybody can be captured. So what does that mean? You can increase the speed, you can do whatsoever you want to do there. And for those that do not have our stuff, I will try to encourage you, try to get it. You won't be disappointed. Use it, and like it will really make you be able to have an idea of what is going on. But the problem is when people are listening, they don't listen. They listen to them while lying in bed, while eating suya, while fighting with their partners, while doing like they are not really focused. Do you get it? So, and they are telling them, don't worry, I will soon pass. I will show you. I will soon pass. First of all, pass first. Do you get it? So, focus very well. So, I would encourage those that don't have it. You can reach out to us through any of our, ask for the secretary's number, get it, just use it, and you see that it's going to be helpful. The last thing I want to say is that likely next week, maybe I will take you further in the cardio. Yeah, next week, maybe either Monday or Tuesday, I will take you further in the cardio. Like we'll look at it, just to go a step further. I don't know the day it's going, but it's definitely next week. I'll take you a step further in it, It might be a day towards maybe Christmas or a day after Christmas. At least as you are eating the meat, you are also learning the stuff.
Thank you,
So
sir.
don't thank me here so that I don't change my mind. Sorry. It's not easy on my own part. Do you get me? But I would love to do that for you. And also some other part of the exam. All right. So go back, enjoy yourself, be happy. This life is short. Right. Thank you, everyone. Bye.
Thank you so much, sir.
Yeah.
Thank you.